Everyone, Dr. Alekhya. Welcome for today's class. That is, we are starting the Farre series for the fourth prof students. And in that, today we are going to learn about orthopedics. Guys, am I audible and visible? Yes, a quick thumbs up will. Am I audible? Waiting for your reply. Yes. Okay, thank you, Bharat, Arti, and Akash for confirming. So let's start the today's session. So, guys, before that, I want to tell you this is a very, you know, very good session for all those prof students who wants to score good marks in their university exams. And this foray is mainly related to those repeated questions which are asked frequently in our university exams, and now we are going to deal them in a great detail, question by question, understanding each thing, so that you don't miss out any point. And I hope you all attending these classes will land up in getting distinction. Okay, so from orthopedics point of view, I'm here today to clear all the doubts or whatever problem you have regarding the subject, regarding orthopedics. And today's topic is trauma. So mainly, if you see in ortho, we have two sections, right? The first one is mainly the trauma, the hot, the orthopedics, and the second one is called the cold orthopedics, where we have the infections, the inflammatory disorders, and then we have the oncology, then we have the pediatric orthopedics, right? And then we have a smaller topic of for sports medicine. And sometimes we may even ask questions from the those important affections of soft tissues, like mallet finger and all those. So we will complete all these topics in detail in the coming sessions. So for today I have come prepared with trauma. So let us solve all the questions which have come in the past years related to trauma. Fine, everybody are with me? So today the topics which we are going to. What is that code language? I did not get. Okay, so the topics today we are going to cover is, first we are going to start with our very important fracture, right? So orthopedics is nothing but full of fractures. Mainly whenever you visit your casualty, usually they get exposed to these trauma, right? So today we are going to understand what is a fracture, how does it heal, what are its complications, and what are those important fractures which you need to read for your university exam, right? Good evening, Kalai. So let's just not waste any of our time, and we'll start the class. So I'll be little quick and I'll be talking everything in detail. If you have any query, you can stop me at any point of time. Okay, you can put the message so that I will reply to your text message. Okay, hello. So let us start from the definition of what is a fracture. So whenever they ask you any question in the exam related to trauma, related to the fracture, first you have to, yes, good evening, Jitendra. Schedule, I think it is there on the app. If it was not there, Shivam, I will let know our tech team to put up the schedule again for you. So all these Farre classes, no, for fourth prof, they are starting at 6 o'clock, okay, in the evening. And your MedEd clinics, again, ortho, psychiatry, radiology, all the short subjects, no, we have started for fourth year students. It is for at 8:30. Okay, Amir, I will let know the tech team that all the notes have not been uploaded. So now let me start orthopedics for today, guys. Okay. Okay, now. So whenever you're answering any question in the exam, always start your answer, especially in ortho, you have to start with definition. Because as such, ortho is a new subject to you. If you start from definition, the examiner will get impressed. And I want you all to know that any highlight, I mean, like if it is a definition or clinical features, or it is a subdivision, just underline it or write it in capitals. So now थर्ड ईयर कब स्टार्ट होगी, आई डोंट नो थर्ड ईयर के बारे में, फोर्थ ईयर में कुछ है तो पूछो. Okay, so now we are going to put just an other ink, like if you're writing in black, right, underline this particular subtopic, I mean like whatever the divisions you're putting in blue. Okay, so first, what is a fracture? A fracture is nothing but which results in loss of continuity of the bone. It could be any bone. So actually, if you know, the bones are continuous if they palpate, right? So now whenever there is this loss of continuity of the bone, or you can even tell as a breach in the cortex. Breach in the cortex. So if you know, the bone is made up of cortex and medulla. So whenever there is some problem or some division in the breach, I mean some division in the cortex. Okay, Shubham, I will ask them to update the remaining notes in Farre. Fine. Okay, for some time, put all your tensions aside and concentrate on ortho class for now. Okay. So, yeah, we'll see to that. First, let us complete what is there in that, and then I will come back to what is not there in Farre. Okay, Shubham? Okay, now please cool for some time and let me complete this trauma in detail. Okay, let us not waste the time on things which are not under our control. Okay. Okay, now as I've told you, so now let us start the definition of the fracture. This is loss of continuity of the bone or breach in the cortex. So why does usually patient land up in fractures? So this fracture can be as a result of a force, right? That is nothing but a trauma. Okay. So usually that force which will result in fracture, we call it as trauma, right? So this trauma is nothing but a force. What is the definition of force? Force is nothing but mass into velocity. So depending upon this force, whether this is an high velocity fracture or a low velocity fracture. This is very, very important. So now we have understood what is the definition of fracture and what was the question asked. The question is about the classify the bone fractures. This is a very basic question. So sometimes they can ask you such basic questions also. And now understanding this fracture first can make you understand the other fractures easily. Right, so let us not waste the time. So now this fracture is nothing but a loss in continuity or a breach in the cortex. Why does this fracture occur? Because of some injury. This trauma is nothing but an injury, and this injury is due to some force which is being applied to the bone, and now it is causing the bone to break. So this force can be of a high velocity force or a low velocity force. So whenever this is a high velocity force, what will happen? There are certain particular fractures which can occur with this high velocity force, such as the first one which you have to put in your mind is open fractures. So when I say open fractures, immediately you have to think that there are something called as closed fractures. Let us first understand the names and then I'll tell you the definition. So first is an open fracture. The second, with the low velocity, it could be a closed fracture. Now tell me, what is the definition of an open fracture? So this open fracture is whenever the fracture fragments in contact with the environment, right? So whenever the fracture is in contact with the environment, so whenever there is a breach in the skin, so this bone is covered by soft tissue, then skin. So whenever there is a problem in the skin and the soft tissue, and now the fracture is getting contact with the environment, then that is called an open fracture. Very, very important. So whenever there is a high velocity, if the patient tells you that he has come as a result of a high velocity. So this is also called as mechanism of injury. So I've told you fracture will occur due to injury, and there is some mechanism to this injury. So this mechanism of injury can be because of a high velocity or a low velocity, right? So whenever there is a high velocity fracture, it will result in open fracture. And what is the other type of fracture which it can cause? It will usually replaced in displaced fracture. So whenever there is a fracture, it will result in two fragments, right? The bone, this is a bone. And when you want to break it, it results in two fragments, right? So these fragments can be displaced, or these fragments, whenever with a low velocity forces, can be undisplaced. Displaced or undisplaced, right? And then this high velocity will result in what is called a comminuted fracture. What is comminuted fracture? Whenever the fracture fragments are more than two. Fracture fragments. I've told you, no, the bone will break and will result in two fragments. When these fragments are more than two, that means it is a comminuted fracture, right? And this low velocity will result in what is called as a simple fracture. Simple fracture. Understood? So this is a basic classification you have to remember. And now I even want to tell you this displacements in fracture, right? Displacement in fracture. So whenever there is a fracture, I've told you this is a fracture, and this will result in displacement. So this displacement can be just a shift or an angle or a rotation, right? So now these fragments, whatever there, they can just move aside like this. This is called as a shift. This is called as a shift, and they can angulate. So this is called as an angulation, and they can rotate. This is called as rotation. Understood? So you have to remember that L, A, R. So whenever you're fixing or reducing, you have to maintain the bone length. You have to maintain the bone alignment and rotation. Understood? So this particular bone, whenever breaks, will get shifted to the opposite sides, or can get angulated to the both to each other, or completely the fragment rotates, right? So on the x-ray, you have to decide what is the problem with that fracture, and then you have to reduce to maintain its length. So you have to bring back the fracture original length, I mean that exact length of the bone, and then you have to see that the bones are aligned. They're not angulated, they're aligned to each other. And then you have to see they're not rotated, and again they are aligned to each other. So you have to correct the rotation, right? So that how do you reduce, we'll see in each fracture, which is different. Now for now, remember, whenever they are talking about displacement, that displacement can be of three types, right? It could be just a shift, or it could be an angulation, and it could be a rotation, right? And now whenever you say this displaced fragments, or whenever you say comminution, there are certain patterns which you have to remember of the fracture. So just a bending force. So again, the force will decide the pattern based upon the force. If it is just a bending force which is acting on the body, this will result in a simple transverse fracture. Understood? Simple transverse fracture. So whenever there is a bending force plus axial compression. So what do you mean by axial compression? What do you mean by axial compression? So compression is nothing but pressing, from above, you're pressing it like that. And again, you're bending. So whenever there is a bending and axial compression will lead to what is called as an oblique fracture, right? And whenever there is a twisting force will lead to a spiral fracture. And I've told you there are many forces combined, and high velocity will result in what is a comminuted fracture. Again, a high velocity forces when acting at two different areas can result in what is called as a segmental fracture. So fracture one above, one below, which will result in an isolated fragment of the bone in between. This is called as a segmental fracture. So this is called as a segmental fracture. Okay, so this is the classification which you have to remember, right? So first, based upon the force, you have to remember that there would be a high velocity. Whenever it is involved, it causes an open fracture. Low velocity usually will result in a closed fracture. Again, this high velocity, because the force is high, it will result in displacement, huge displacement. Whenever the force is low, it can be an undisplaced. So it will just, there will be a crack in the fracture. There is no movements in the fragment. That is the undisplaced. And again, you know what is a simple fracture? What is a comminuted fracture? Simple is just a transverse fracture. So this is a simple fracture, simple transverse fracture, right? And this is a comminuted fracture. When the fracture fragments are more than 2. So this is a comminuted fracture. Now, there is one more thing which you have to understand. So I have told you that there is a force which is acting, right? And I've told you this is high velocity and low velocity force. And sometimes there would be no force at all, but patient comes with fracture. This is possible when the bone is very, very weak. So when the bone is very weak, it will result in what is called as a pathological fracture. It will result in what is called as a pathological fracture. So now this is an example of the pathological fracture. If you see this particular X-ray, you can see that this bone is abnormal. Usually the bone has to be like this, right? It has to be white in color, dense. But here if you see, it is like this, little darker shade, right? Lucency. So this is some cyst which is present, and even there is no force, the patient has landed up with fracture. So this is what is called as a pathological fracture, right? And now they could be low velocity forces, but because of the chronic repetitive forces, like for example soldiers, for example, you know, the soldiers, they continuously march. So whenever they're newly recruited soldiers, they continuously march, they put their pressure on the feet. So this might result in a second metatarsal neck fracture. So this is a classical example of what is called as a stress. I think you need not know what is stress. We are already in so much of stress, right? The chronic repetitive forces, chronic, you know, if the teacher daily she keeps scolding you chronically, repetitively, your brain gets shattered, right? You don't like that teacher, or you don't like reading. So you go into depression. That is regarding the brain. So regarding the bone, if this is chronic, if this is repetitive, if this low velocity also, smaller forces also will result in what is called as a stress fracture. Here again, the patient will not give you any history of trauma. Will tell you that, yes, yeah, March fracture. He will tell you that they will usually come with a swelling or a pain. That's it. And when you ask them in detail, no, what is your complaints? They just tell there is a pain there. When you get the X-ray, you will see that this is a fracture, right? So that is about the classification of the fractures. So in the exam, you're going to write in a great detail whatever I've told you. So first you will put the heading as definition, and you will give nice underlining to it so that the examiner will not miss what you want to tell. And then you will write the definition of the fracture. And now, instead of writing like this, you can also write like this. So this is the classification based upon the etiology. Now you know, because whenever the force is involved, the injury is involved, it is traumatic. No force is involved, it is pathological. And whenever there is a repetitive trauma, repetitive force, low force, that is called as stress fracture. But what is the difference? You will write pathological, it is an abnormal bone, because bone is weak, hence no force is required. But here what you write in repeat stress fracture, here you write the bone is normal. So whenever you're writing such contrary statements, bone is normal, bone is abnormal, again you will underline it. That is based upon the etiology. Next, again, whenever it is exposed to the environment, you say it is an open fracture, and whenever it is not, you say it as a closed fracture. So this is one of their classification. So first, based on etiology, second, it is based upon environment, and third one, displaced and undisplaced. So whenever you're talking about displacement, you can write there are three things can be done, which can be seen, that is a shift, angulation and rotation. So that is displacement. So whenever you're talking about displacement, the next thing what you talk about is the pattern. So once it is displayed, the fracture can also be classified based upon the pattern, such as transverse, oblique, spiral, comminuted, segmental. So here you can add certain words such as the forces. So whenever bending force is used, you say it's a transverse. Whenever you say oblique fracture, such as axial compression is used, plus bending forces is your oblique, and twisting forces which will result in spiral, and high velocity can be as a result of comminuted and the segment, right? And then simple and complex. So depending upon it is whether it's just a simple fracture or a complex fracture. Complex is nothing but a comminuted fracture or a segmental fracture again. Okay, finally he has told us high velocity, low velocity. So we have derived this particular thing, which is very, very easy. So if you remember this, you can write the entire thing. So just remember the displaced fracture. You have to put one more line for yourself, right? And whenever there is displacement, you can also comment upon pattern. So that completes the classification of bone fracture. Is that easy? Anything you want me to explain? So this is an example of an open fracture. See, this is an example of open fracture, right? So this skin gets breached and the bone gets exposed, right? Okay, that is about the classification of your bone fractures. Yes, is that okay? Anything you want me to explain more about classification of bone fractures? We're going fast, slow, okay pace. Come on, it's Shubham. Okay, Pes Jitendra. Okay, Jess, thank you. So now that is about the classification of fractures we have done. Now next we are dealing about the stages of fracture healing. So what the question was, what is the stages of fracture healing and what are the factors affecting the healing? And they have also asked us to discuss the complications such as delayed union, non-union, malunion. And finally, they have told us to differentiate between primary, secondary bone healing. This is very, very important. A 10 theory question. Okay, again, starting with definition. So we know anything in ortho, we will start with definition. And again, we know that we are going to underline it with the opposite color so that it gets visible to the examiner. So here, whenever you're doing this fracture healing, no, and one more thing, surgery, that means whenever you're writing subjects like anatomy and ophthal, ENT, general surgery, orthopedics, and obs and gynae. That means all the surgical branches, no, you have to draw the diagram. Okay. If you draw diagrams in the medicine thing also, it is fine, but see that at least one diagram. If you're talking about fracture classification, just put this diagram. So this is the shift. Just put this diagram. So this is angulation, like that. Something you draw. Okay, but see that at least there are, if it is a 10 marks, see that at least there are two diagrams. It is a 4 or 5 marks question. See there is a one diagram. Understood? So, and one more thing, if you want to put up something in the boxes tabular form, that will be even more welcome, right? So this examiner, whenever he's reading your paper, he will just first initially he will go through like this, and then he starts reading. So when they go through like this through the papers, so they will see this first, the diagrams, then the tabular forms, then your line diagrams, like I have drawn this, no, this line diagrams. So whenever they see such things, they get impressed, right? And then there are high chances of getting at least those tiny extra marks. Okay, so again, let's start with the definition. So what is healing? Fracture healing. So as we all know that bone is a special tissue. So any healing is nothing but it ends up in fibrous tissue. But what you have to write, fracture healing is a very special mechanism which in which the end result would be mineralized mesenchymal tissue. So this is very important, right? If you write such words, no, it will be very easy. So what is that mineralized mesenchymal tissue? It is nothing but bone, right? So any soft tissue result, the end result would be a fibrous tissue, right? But what is the specialty of our bone? The bone again will form, the end result is bone, right? So that is the importance and that is the beauty of fracture healing. So how does this occur such beautifully? So this occurs in 5 stages. Okay, now they have made it only 4 stages. Recent update. So now this is through the stages. These are called stages of fracture healing, right? These are called the stages of fracture healing, right? And what are those stages? This is like a story. You listen like a story and then we'll put up. So first is stage of hematoma. So what happens? Just imagine that some person is walking on the road and there is a dash from a vehicle, maybe a car or a bike, and he has fell down. So this dash is exactly just below the knee at the. So now the patient has, it is a high force injury. So now this has resulted in fracture of the tibia. So once there is a fracture, what will happen? The bone is vascular, especially with the periosteal supply and the medullary supply. So you have to understand the supply, blood supply of the bone. It has some vessels which are called the metaphyseal vessels, which is artery. Then it has the epiphyseal vessels, right? And then it has the periosteal blood supply, right? So this blood supply is there. So hence, whenever there is a fracture, there is a bleeding. So this bleed of the vessels will result in between the fragment. No, whenever there is a fracture, it will result in two fragments like this, and this is your hematoma. This is your hematoma. So the first stage is stage of hematoma. Do you think it is as simple as I told you? No, because this hematoma is rich in what is called as the growth factors, right? This is very, very important. So in the past, what I've done is, in the past, maybe some 10 years ago, so we have a special association which is called AO. AO is some, not association of orthopedics, this is some other term, I'll tell you later. So this AO principles what we follow for bone fixation, right? So initially, whenever, I mean, like 10, 15 years back or 20 years, the AO principles was whenever there is a fracture, you remove complete hematoma and you try to bring the fragment together and fix it with a plate or with the nail, whatever you want to use the fixation, you fix it. But now, recently, I mean, past 10 to 15 years, what happened is the biology of fixation is changed. Why it is changed? Because we came to know that this hematoma of fracture fracture is very, very important. This hematoma of the fracture is very, very important. Why it is very important? You have to write this point because the growth factors, the blood, there is a rupture of the vessels and there is a bleeding, and this bleeding, and there will be necrosis of the fracture end, and this bleeding and necrosis will invite a certain cytokines, certain interleukins, certain BMPs, bone morphogenic proteins, finally your vascular endothelial growth. So this is, so whenever you're writing fracture healing, so first you're going to write the main important thing that the end result is bone here, and you know there are 4 stages of fracture healing or bone healing, and the first stage is stage of hematoma. In that you will write this usually occurs 1 to 3 days. So initially 2 up to 3 days you see this stage of hematoma where there will be a um, where there will be a lot of growth factors which are present. And then it will enter into the second stage, which is called stage of soft callus. Okay, this is up to 3, right? Important, underline. This is important, underline. So you're going to tell there is a stage of soft callus and going to underline it. So what happens here? So once there is a fracture of hematoma, and after 3 days, what happens is the granulation tissue. Granulation tissue is nothing but again a fibrous structure, right? So there will be a mesh of the granulation tissue, and over this, what happens is there will be mesenchymal stem cells. So these mesenchymal stem cells will undergo transformation into osteocytes and chondrocytes, and now they lay the bone here. So soft callus is nothing but they lay the small amount of bone which is not very strong, but a bone is laid, and now what happens is the important point you write here is the fragments get, so that is the important point, the fragments get sticky. So that is when you'll see this 3 weeks. So whenever a patient takes x-ray after the fracture at 3 weeks, you can find this, you can find small amount of callus, right? Then comes the third stage, that is stage of hard callus. So that is stage of hard callus, right? What happens here? So now we know that the end results of the bone fracture healing is bone. Now this soft callus, whatever is formed, now becomes hard because of the osteocytes which are present. Now they mineralize this, and this will result in what is called as a hard callus. And for the formation of hard callus, it takes 3 months. And now from here onwards, there is no chance of manipulation of the fracture fragments. So you have to be very careful. So before 3 weeks only, all your manipulations should be done. Like if you want to restore the length, you want to restore the alignment, you want to restore the rotation, everything should be done at the 3 weeks. After 3 weeks to 3 months, what happens is there is a ossification of the callus. So this will become hard. So there will be ossification of the soft callus. So that is the word which you have, right? So this ossification of soft callus will result in what is called hard callus. Now this will be seen very, very clearly on the X-ray. So X-ray at 3 months, when you see the hard callus, then you can be assured of the union. So what is union? What is union? Union is nothing but the fracture fragments are coming together, right? So they are uniting. The fracture fragments are uniting. That is called as union. And finally, are you happy with this union? No, you want the bone to be as normal as before. So this normalcy is attained by the bone by a process of stage of remodeling, and this takes 3 years, right? So this takes 3 years. Again, underline. So if you remember, 3 days, 3 weeks, 3 months, 3 years. This is stage of remodeling where the bone becomes exactly like normal, right? So this remodeling is nothing but it occurs through a process of osteoclast removing the bone and osteocytes laying the new bone, the pattern of stress provided bone. Understood? So that is why what we are doing here. So this is the stage of remodeling. So what do you mean by that? What do you mean by in pattern of stress and all those? It is little hard to understand, but it is very easy. What is that is, if you see your femur bone, it is at a shape, right? It is somewhat like this and then it becomes like this. So there are certain shapes to each bone. Why do you think that shape has come to tibia, fibula? That is the stress. You put weight more on the medial side, so bone is formed more on the medial side. If you put stress less on the lateral side, bone is weaker on the lateral side. So similarly, once this hard callus has formed, after 3 months, if you see, we usually allow the patient to bear weight. So once the patient starts bearing weight, because of that stress which is provided, because of that weight bearing, there is a remodeling that is happening, and this is by the help of our very important osteoclast, where they are useful for removal of the bone, and osteocytes will lay the new bone in that particular pattern of the stress. So this is called as remodeling, and it will take 3 years. So when this remodeling is done, the patient can go for implant removal if there is any implant which is put up in stage, right? So that is after hematoma is formed, we are operating the patients, right, for fracture healing. So this is the stage where we remove this implant. So after 3 years, we usually can remove the implant. So the purpose of the implant has been served. Now the bone can take up the weight on its own. Understood? So these are the stages of fracture healing, right? So now we have completed the stages of fracture healing. These are all the important points which you have to remember. Just remember for hematoma growth factors, and you can mention certain cytokines, interleukins, certain BMPs, all. And then you have to remember stage of soft callus, where you have to mention about this particular fragments getting sticky, right? And manipulation is still allowed here. So if you still want to manipulate fracture fragments, you can do it at this stage, right? But when it comes to hard callus, no manipulation is allowed because now the bone has become really hard. And finally, it will end up in remodeling. So now we are going to write this particular important table in your exam whenever they ask about hematoma. Remember 3 days, weeks, 3 months, and 3 years. So this is the easy way for you to remember, right? And don't forget to draw the diagram. So exactly it should become like normal. This is the normal bone which has broke, and it has crossed all the stages like this, and now it has come to the final stage, which is sometimes, this x-ray, if you show, they don't even know that patient has some fracture in the past. That is after 3 years. That is the beauty of the remodeling. Is that clear? Anything you want me to repeat? Sharat, Shubham, Kalai, Jitu, Akash, Arti. Is that okay? Fractures of stages of fracture healing. Okay, now let us go to the one more thing. So what I want to tell you is two important concepts here. So one is endochondral ossification, and the second one is intramembranous ossification. This can also be asked as a 4 mark, so I'm just including it. Right. So what is this endochondral ossification? Endochondral ossification. So whatever we have learned. So first we have learned there is a cartilage cells which are formed, and then those are converting into the bone matrix, right? So this intermediate of cartilage, whenever is present for bone formation, that particular ossification is called as endochondral. Chondral matlab chondrocytes, like cartilage. So this is all your endochondral ossification. So whatever the stages I have mentioned, those are your endochondral ossification. So we are taking help of the cartilage cell, which are acting as the intermediate. Okay, it's like the intermediate. Yes, hyaline cartilage ossification, that is endochondral. Then comes the intramembranous. So whenever there is a membrane and directly ossification occurs on it without cartilage in between, without cartilage. So that is your intramembranous ossification. Intramembranous ossification. So very important example is all your skull bones and clavicle, the long bone, and endochondral, all long bones, right? So that is the two important ossifications which you have to remember. That is endochondral ossification and intramembranous ossification, right? So one important word which you have to remember is cartilage. Whenever the cartilage is acting as intermediate, the word itself self-explanatory, endochondral. If that is not there, it is intramembrane, right? Okay, done. And now there is one more concept which you have to understand: the healing of bone can be of two ways. So one is called the primary or a direct healing, secondary, right? So primary or a direct healing, secondary or a indirect healing. So whenever you see the healing of the bone, so now we have understood that, so this particular bone is a shaft. Let us assume this is the shaft, but there is one more bone, right? And the fracture happens here, right? So this is around the joint. So let us understand what is happening here. So primary healing and secondary healing. So primary healing is what where we achieve a anatomical reduction, right? And there is no callus, no micromotion which is present, right? And then it is mainly for the periarticular fractures, right? So when you want to talk about the reduction, it is anatomical reduction. And here what happens is absolute stability. Here, no anatomical reduction. So this is nothing but relative stability, right? and here there will be lot of callus which is formed. Movements here is micro movements, is shaft of long bones. So this is very, very important, which you have to remember. Now I will explain you what is all this. So don't get angry that I'm speaking all Greek and Latin. So first is, let us take the example of the shaft. So let us assume this is tibia. So as you all know, tibia is a long bone and it is a weight bearing bone. So we need the strength back in the bone, right? So for that, we will allow callus formation, right? So callus formation we will allow because we want that bone to be as strong as it was before. So how this callus is formed? This callus is formed only by indirect healing, right? Indirect healing or a secondary healing where some gap is left, and this gap will result in what is called as micromotion and will result in callus formation. So how will you achieve it? So we will put a nail in this. So whenever you put a nail, so you put a nail and you're fixing it with the screws. So whenever you put a nail, there is no absolute reduction. That means the whatever the fragment gap is there, no, you see that they just come close by, that they're not into it. So this is absolute reduction. So there is no gap here. This is absolute reduction. But what is relative? So there is a small amount of gap which is there. So whenever there is a gap which is present, the fragments move. This is called as micromotion. This micromotion or this movements are controlled by the nail. They are not so gross like this so that the fusion doesn't occur. It is very, very minimal. Because whenever there is a minimal gap which is there and minimal motion which is there, which is controlled by our implant, there will be callus formation, right? So for long bones, we encourage this callus formation. For example, your fracture shaft femur, fracture shaft tibia, long bones, right? And then coming to the periarticular fracture, for example, the very good example I want to tell you is your forearm bones. So forearm bones, what happens is, for example, your radius. So as radius and ulna are long bones, but still, because we considered forearm as a joint, because there is an interosseous membrane which is present, right? So we don't want callus. So anything around the joint, we don't want callus, because if callus is formed in the joint, what will happen? It will restrict the joint, right? So they will not encourage any callus. So whenever there is a periarticular fracture or fracture forearms, what we do is we reduced it in such a way that, it is locked and there is no gap, is completely locked. So this is called as absolute or anatomical reduction with no gap in between. Whenever there is no gap, there is no callus form, right? And this is achieved by your plates, your implants. So you put the screws, these are the two screws with the plate, two screws with the plate. So whenever you fix it this way, this is an absolute or anatomical reduction where there is no callus, no micromotion, and the examples are your periarticular fractures for primary healing or direct, and shaft of long bones for long or indirect, right? So this is very, very important. Primary healing and secondary healing or direct or indirect healing. Is this clear? Any doubts you have regarding this? So clavicle is mainly intramembranous ossification. As we know that it is the only long bone with the intramembranous ossification. It has two ossification centers. Ossification is by intramembrane. Okay, now are you clear with this primary healing and secondary healing? Okay, Sanjay. Yeah, thank you. So that's it. So we have done with the stages of healing, and then with primary healing, secondary healing, and we have also known the difference between the uh, enchondral and intramembranous ossification, right? So now let us see what are the factors which influence this healing. Thank you, sir, the surgery guy, for such kind words. So now the factors. So these factors, if you remember, this can be divided as, the patient factors, the fracture factors, and the surgeon factors. So now all this, why we are learning so much about, what is stages of healing, how should it heal, why should it heal, and all, because we want the fracture to unite, right? Everything we are doing here is for the union of the fracture. That you have to remember. Whatever you do, the fracture should unite, but this union should be according to the length, angulation, and rotation, right? So now there are certain patient factors where they may hinder the your healing process. So first one is age, right? Age, and the second one is the nutritional status of that particular individual, and some metabolic disorders such as diabetes or hypothyroidism, right? And then the fourth one is very, very important, smoking and alcohol. Okay, all the boys, please listen, that smoking will hinder fracture healing. Even you're a doctor, there will be some problems in healing, right? Smoking and alcohol is dangerous for bone healing also. And then metabolic disorders, I have told you, such as diabetes, mellitus, and hypothyroidism to some extent, and nutritional status. Whenever poor nutrition, malnutrition, there is no a nutrition to the bone, there is no proper calcium, there is no proper vitamin D, so obviously there will be delay in, right? And age, as children, they heal really faster. So when it comes to children, it heals really faster, and when it comes to old age, above 70, above 80, again the healing will slow down, right? So those are patient factors, right? And then comes your fracture itself. What are those important things? So first and foremost, what you have to remember is the open fractures are very, very notorious. Open fractures are very, very notorious. And then if there is a loss of bone, or if there is any fracture fragments, interposition between them, or tissue interposition, right? And type of bone, the cancellous bone heal well, right? The cancellous bone heals faster than the cortical bone. So if it is open fracture, there is a loss of bone, if there is a fracture fragment, tissue imposition, type of bone, right? Again, your open is, again, it might result in infection. So whenever there is an infection of the bone, so all this will result in, again, problem in the union of the bone. And what are the surgeon factors? So surgeon is also playing certain important role in the union. If the proper fixation is not there, if proper immobilization protocol is not performed by the surgeon, okay, and then reduction. So if the surgeon doesn't reduce well, if the surgeon doesn't fix it well, so wrong choice of implant, or there is an implant failure, or if the immobilization protocols have not been followed well, then also it will affect the union of the fracture. So these are certain important things, right? These are the certain factors which you can remember, right? So if you remember like this, it will be easy for you to put in the exam, or else you can even write as extrinsic factors or intrinsic factors. Extrinsic, like, open fractures, loss of bones, soft tissue interposition. Intrinsic, such as age, your type of bone, right? Fixation, these all are intrinsic factors, right? So these are the factors which are affecting the healing of the bone. And then now I'm talking so much about union. So what are the complications? What are the complications of this fracture healing? So there can be three important complications, such as delayed union, non-union, malunion. So what is the difference between these three? So coming to the delayed union, what will you write if it is a delayed union? You understand that there is a union which occurs but delayed. But delayed. Very easy. Delayed union, union is delayed. Then what is non-union? Non-union. So not uniting, right? So again you write non-union, not uniting, right? And again you write malunion. Here the bones unite, but as I've told you, LAR. What is LAR? Length, alignment, rotation disturbed. That means no alignment in short. So when I say there is no alignment, it means mal-aligned. So it is mal-union. So understood? So whenever they ask you the complications, these are the important complications of fracture healing. So first one is delayed union. So whenever you take a soft tissue, yeah, that only next point I'm telling Kale. So whenever you take a bone healing, usually by 3 months for an IC fracture, it is usually for 3 months. Any other bone, it depends upon its bone variety, but arbitrary we take it as 9 months. So whenever in 9 months you take repeated x-rays, and if you see there is no callus which is formed, then this is called as non-union. From 6 months to 9 months, you can still wait, right? So usually by 6 months, you see there is a union, but from 6 months to 9 months, you can tell it as a delayed union. But here what happens is no surgical intervention is required. So now you may ask me, what is the difference between delayed union and non-union, whether the time gap or something else? So I will tell there is a something else which you have to remember between delayed and non-union. That is, in delayed union, what happens is no surgical intervention. That means the surgeon need not intervene for that union to occur. But non-union, what happens is the surgical intervention is required. Surgical intervention required. If you write this 1 point, no, they will give you 100 marks. So this is the basic difference between delayed union and non-union, right? So the time limit is arbitrary 9 months. That is fine. But what is very, very important is now the surgeon has to treat the fracture. He has to open the fracture. He has to deal with the fracture. Then only the union occurs. But for delayed union, you need not do anything. You have to just wait. But make sure that everything is perfect on the x-ray. Everything is perfect with the patient. Then only you have to wait. Understood? So now these are the two important x-rays which I want to tell you. This is x-ray A. This is x-ray B. This is x-ray C. Now quickly tell me what is x-ray A. Quickly. What is X-ray A? It is united or uniting, or what happened? There is some problem with the union. So if you see, this is one axis, this is another axis, right? So usually what happens is the long axis of the bone should be straight like that. Yes, Kalai, very good. So one axis you can draw like this, one axis you can draw like this. That means it is a malunited fracture. Perfect, malunited fracture. Usually where you see fracture, in Colles fracture, right? So this is your malunion, right? And what is, yeah, what is B? Yes, very good. These two are non-unions. Very good. So we have two things in non-union. So non-unions can be divided into three classification. Okay. So first one is your hypertrophic non-union, and third one is atrophic non-union. So in between we have what is called as oligotrophic. So what are again these Greek and Latin terms? Again, I'll make it easy for you, nothing to worry. So first, let me make you understand that fracture healing, as we learned, what have we have learned, how it is happening? Three stages, right? So the first thing, what is important is the biology. And the second one, what is important is the mechanics. So what do you mean by mechanics? That means stability, right? So it is like if you want to crack an exam, first thing what you need your interest, right? And second thing, you need the consistency. So here, if you're not consistently reading, you will never crack the exam. First, if you don't have that instinct to read only, then you will never pass the exam. Similarly, the fracture union also, it requires two things. One is biology. Biology is nothing but vascularity, because everything is your hematoma, right? I've told you the hematoma is very, very important. It has having all the growth factors. It has to have good vascular supply, good nutrition, so that the bones, the healing is good. And the second one, it requires good stability. If the two fragments are like this, if they are moving continuously like this, how will the bone form? How will the callus form? How will the bone unite with each other? It will not unite, right? So it requires vascularity, that is biology of the bone, and it requires stability, that is mechanics of the bone. Now what happens? So based upon this, they have divided non-union into three types. One is hypertrophic. Hypertrophic. So where the biology is good. Hypertrophic is biology is good, but stability is not there, right? So this is for your hyper. Okay, sorry. I'll write to this. So this is your hypertrophy non-union and atrophy. Oligo is understood. So remember only these two, hypertrophic and atrophic. So whenever I say hypertrophic non-union, that means vascularity is very good. The bone is healthy. The bone is vascular. Everything is good. But what is not good? Stability. There is no stability for it. Atrophic, there is no vascularity. There is no stability. Right? In somewhere you can tell oligotrophic is where some little vascularity is present, some little this thing is present. And here it is mainly the biology which is important. So whenever I say atrophy, the vascularity is usually not present, but the stability may be present, may not be present. But the problem is mainly the vascularity, right? So that is why they have divided into hypertrophy and atrophy. Understood? So hypertrophy mein there is good vascularity but no stability, right? And atrophy, vascularity is not there, absolutely zero. Stability may be there, may not be there. Even though good stability is there, because there is no vascularity, it is still atrophy, right? So that is the difference. So whenever there is this atrophy, this is also called as gap non-union. So there is no callus which is formed. Here you can see there is callus, because atrophy, completely no callus, because no vascularity here is present. So that is why B is hypertrophy. This is gap. This is atrophy. So that is about your non-union. Mindful study sessions. Does this lecture help physios? Yeah. The good thing is you can listen to this lecture and let me know whether this is helpful for the physios or not. Okay, understood. So this is a hypertrophic non-union and atrophic non-union, right? So here what you see is because of this callus formation, you can see some amount of callus which is formed, and this is usually called as the elephant foot type. So in atrophic also there are types not required for your level. Just remember elephant foot, that is like this, right? So here what you see is completely no callus. So this is atrophic non-union. Very, very important complication, right? So this is malunion, this is non-union. And oligotrophic is somewhere in between, where there is little lack of vascularity, little lack of stability, and together will result in this. So now you have to decide whether the problem is in biology or stability. If the problem is in biology, what you do, you put the bone graft to that particular area, so that there will be good healing which occurs. If the problem in the stability, you will fix it. You will increase the fixation, like you can add an additional plate to it, or you can remove the complete implant and redo the implant. So that is how you treat the non-union. Fine. So that are the complications which we have discussed. So they have told us to write about the fracture healing we have done. So stages of fracture healing done, factors done, delayed union, non-union, malunion done, primary and secondary bone healing done. So this is about your 10 marks question. So you will write all the important points there so that yeah, atrophic, you exercise the sclerotic ends and autologous bone grafting. That is true. But again, you have to even check for the stability also. If it is not stable, again, you have to increase the stability. But usually, whenever it is atrophic, the most important treatment would be bone grafting. Right? Yes, Kalai, very good. Okay, done. So we are done with two questions, two important questions, that too. And then we are going to the fracture complications, right? Is that clear, guys? Any doubt? Sanjay, your clearance? Okay. Okay, now let's deal with the third set of questions. So now fracture definition, classification is done. Then we have dealt with fracture healing also in great detail, and the types of healing and all. So why I've done in a great detail, because see, listen, this can be also asked as a question. So they can just ask you what is delayed union, what is not, or they can just ask you, what are the examples of this malunion and how do you treat it? What are the examples of non-union? So let me quickly tell you, the treatment of any malunion is generally it is osteotomy, right? And non-union, as we have discussed, as Kala has told us, it is usually bone grafting. Whenever there is any mechanical instability, you also fix it. So that is how this can be asked as 5 marks also in between. That is why I have told you in detail. Now coming to the fracture complication, right? So most important question is define fat embolism syndrome, discuss its pathogenesis, clinical features, diagnosis, and management. Yes, explained clearly that you have tried everything in great detail. So this is very, very important again. It unmarks question. So as we all know, we usually start everything with the definition. So what is the definition of the fat embolism syndrome? Well, how does it occur? What is a fat embolism? So whenever there is a history of long bone fracture, fat globules escape marrow, as in the adult, it is the fat which is present in the marrow, right? And result in fat, right? So that is the definition. So there will be a history of long bone fracture or a polytrauma. That means multiple fractures can occur, and this within 24 to 48 hours. This will result in what is called as a, yeah, 48 to 72 hours is also correct. So anything after 24 to 48, right after. Okay, very good. And then what is the pathogenesis? What happens whenever this fat globules escape? There is two important mechanisms which can occur. So first is vasculitis, which you have to remember. Second one is thrombosis. right? So these flat globules, the lipases get released, they act on neutral fats and they cause this vasculitis. That is nothing but inflammation, right? The second one is thrombosis, like they form small clots or they aggregate as small clots, especially in the. So this is the two important pathogenesis which you have to remember. Understood? So first, the definition is long bone fracture whenever it happens after 24 to 48 hours. Usually we see, not between or just as soon as the fracture happens, it doesn't result. So this fat globules, whenever they get released, they result in two important uh, things. One is the vasculitis, that is, they cause infection of the vessels, small vessels, and then they result in thrombosis, that is small clots which are especially in the pulmonary vessels. And what you have to remember is the clinical features. Usually what you have to remember is the triad, will be triad of symptoms. So the first one, as I've mentioned you, that is the respiratory symptoms, where the patient presents with tachypnea, hypoxia, tachycardia, and then have this rash in on the chest, right? And the most important is neurological symptoms. The most important or commonly seen is irritability to coma, right? So these are the triad of clinical features which you have to remember in case of your pulmonary syndrome, pulmonary embolism syndrome, right? And coming to the diagnosis and management. So how do you diagnose? So diagnosis. So first diagnosis is, yeah, breathlessness, fatigue, yes, irritability. These are the triad of symptoms. So whenever you're writing the triad, just draw a triangle like this and write. So first respiratory, neurological, and a rash. So rash is, as he mentioned, this is the petechial rash. So petechiasis. And coming to the diagnosis, as they have mentioned, you can see this fat globules. Fat globules you can see in urine and the sputum, right? And then chest x-ray. Chest x-ray, you see something like the snowstorm appearance, right? Yes. Third one, so partial pressure of the oxygen is very low. Yeah, you can go for the GERDS criteria also for the diagnosis. And this is what is the I am writing for the generally, it's not the GERDS criteria I'm writing. So this is mainly you, yeah, there are major and the minor criteria which you can consider. So usually the flat globules, the chest x-ray, partial pressure of the oxygen, and you will see retinal hemorrhages, uh, clinical suspicion whenever there is a fracture of long bone. So this is mainly, if you remember these things, it is easy for you to write in the exam, right? You can remember it as the core, right? So fat globules in sputum, chest x-ray, oxygen levels, retinal hemorrhages, and your suspicion of whenever there is a long bone, right? So this is, as you can remember it as scored the diagnosis. So again, the GERDS criteria is there, where there are major criteria and minor criteria. So at least two major and one minor has to be there for the diagnosis of the fat embolism, right? And then how do you manage this case? So management. So management is, first, there should be the respiratory support which we give to the patient, right? That is oxygen therapy. And then you treat with low molecular weight heparin. and mainly you go with corticosteroid. So as we know, the management is mainly depending upon the pathology, right? So we know it is a high amount of inflammation, that is vasculitis. So this inflammation you can control only with the corticosteroids. So steroids are anti-inflammatory, so they will help. And low molecular weight heparin again for the thrombus, right? And sometimes IV you can give dextran with the 5% alcohol, which can emulsify your fat globule, right? So there is much more for the treatment. This is not exactly, but this is mainly for your exam, like theory. So this is theory. These are the important points which you have to mention, right? So this is about the uh, fat embolism syndrome. So you have to start with definition, then you go with the pathogenesis that I have told you, the vasculitis and the thrombosis, right? And then we come up with the clinical features, three important things: respiratory, that is tachycardia and tachypnea, what you have to mention. So fever will also be present, and then there will be rash, that is a petechial rash, and neurological symptoms. These three are required, and this rash can occur anywhere in the chest, in the axilla. And then the diagnosis, mainly you write this. Instead of the Gertz criteria, you can write the fat globules, the chest x-ray, and the partial pressure of oxygen. Then retinal hemorrhages, which can be in the striate hemorrhages or just the hemorrhages. And then you have to mainly see the long bones fracture. So it should be a case of polytrauma, right? And then how do you treat it? First, you have to treat always the oxygen therapy going on. Then you supply him with corticosteroids, low molecular heparin, and sometimes you can extend 5% fat globule, right? So that is about your fat embolism syndrome. Next, what is the next complication which you have to remember? Very, very important complication. That is your compartment syndrome. So that is your compartment syndrome. Very, very important, which is usually asked in the exam. So what is the compartment syndrome? So is fat embolism clear, guys? Yeah, again, Gertz criteria is again same. No, all the three important will be the major, and your tachycardia, fever, and all other retinal hemorrhages all will be a minor, right? So usually the major has the one, majors are the one which are very, very important for the diagnosis. Yeah, as Kalai told, two major or one major plus four minor does also help you in diagnosing your pulmonary embolism. Okay, now let's deal about what is compartment syndrome. So as we all know, once we are done with the fat embolism, now the next important thing which they ask you is about compartment. So in it again, they're asking about the causes, pathophysiology, clinical features, and management, right? And including surgical interventions, right? So you have to read the question carefully so that everything is covered in the question. So what is a compartment? So before that, understanding the syndrome, you have to understand what is a compartment. So for that, you have to go back to the anatomy where the muscles of the arm or any part of the body is so all the muscles are arranged in compartments with the help of a very interesting tight structure, which is called as the fascia. So here, this particular compartment of the muscles now has divided like flexors, extensors, right? And they will have their own nerve and blood supply, right? So this is a compartment where there are group of muscles. It has its nerve supply, blood supply, which are covered by a fascia. So for your understanding, so this is a osseofacial compartment, right? So for example, if you take a forearm bone or a leg, there are two bones in it, right? Forearm and leg. So you will see what is called as an interosseous membrane between them. So between two bones, it is an interosseous membrane. So there are two bones here, and this is the interosseous membrane, and this is the fascia, if you see. And now this fascia is dividing into two compartments. So one compartment, this is the second compartment. So flexor compartment, extensor compartment, and that is mainly in the forearm. In the leg, what we have? The leg, how many compartments we have? So as we have discussed, that has a story, the stages of hematoma as a story. I'll tell you the compartment syndrome as a story, and you can write your own. So first, starting with the compartment syndrome, you will explain about what is a compartment. So compartment is nothing but a group of muscles which are enclosed by the fascia, which are having their own nerve supply and blood supply, right? In the forearm, we have two compartments. What are the two compartments in the forearm? Yes, flexors and extensors, right? And then in the leg, we have faster. Yes, very good. Peroneal or the lateral compartment. Yes. So this is what you write as a definition. And now you draw this particular diagram. Just draw. This is as a forearm. You draw and now you put a skin, you put a bone and then a fascia. You write this as osseofacial compartment. So there is a bone which is covered by the fascia. Now what happened? Now very important. Now very important is what is happening to this. And what is this compartment syndrome? So what happens is whenever there is any tight structure right around us, it will hold only a certain amount of volume, right? Whenever there is enough volume in it, what happens is now the volume becomes constant and the pressure rises at particular compartment. Understood? So whenever there is, so for example, if this compartment is having certain amount of volume, it can hold. So there is some edema which is happening inside it, and now it is holding the volume, and there is a high, that saturation point where it can't hold the volume. Now what does it do? It will increases the pressure. So whenever there is a pressure increase, what happens is you have to go back to physiology and you have to know that the blood flow is always from high pressure, low pressure, right? So blood flow is like this. If it is 30 here, 20 here, blood will flow from 30 to 20. Like that, no? So it is always from the high pressure to low pressure. Now what is happening in this compartment? Now the pressure is rising. It is rising. It is rising. So here the blood flow which should happen from high to low pressure, because of raised delta P, raised pressure here, the blood flow will stop. So this blood flow stops. What happens is ischemia. Ischemia is nothing but will result in edema. Again edema. Again it is contributing to volume, right? Again there is increase in delta P. Again there is blood flow stops. So this is like a vicious cycle which happens in compartments. Yes, very good. The vicious cycle. So this is like a cycle which is happening, right? So it is like we study. One day what happens is we start reading and we see the Instagram. And again, what happens at the end of the day, we feel very bad, right? That we did not study the whole day. And next day, because of this feeling bad, again, we want to come out of this bad, right? We want to release endorphins. Again, we go back to Instagram, right? So Instagram will release that dopamine levels, so we feel good, we feel happy, again we'll not study, end of the day again we feel bad. So this is a vicious cycle where the student undergoes, right? So because of that, the edema, what happens is because of that, similarly, like in the bone, in the compartment also, because of the tight structure, the fascia doesn't allow the volumes to expand. So it will control particular volume. So once that volume is full, there will be high pressure. Because of the high pressure in this particular compartment, the blood cannot flow from outside to into this compartment. Because for the blood to flow, the pressure has to be maintained. There should be some delta P, that is difference between two pressures. But now because of this increase in this compartment, it's becoming equal. So there is no blood flow. Once there is no blood flow, there will be muscle ischemia. It will again invite more edema, right? And again, there will be increase in the pressure. So because of this, completely the blood flow stops, right? So once this is happening inside the body, what will happen is first the patient will call you with pain, unexplained pain, and this is not relieved with increased analgesics. So as we practice daily in the ward, in the post-op, we know how much is the pain where patient can, tolerate. It could be soon after the trauma, it could be soon after the post-op. So when you see such disparity between increased analgesic and you see unexplained pain, because compartment syndrome is only by suspicion, there are no clinical tests which can be done, or there is nothing to, you know confirm that this is compartment syndrome. So this is strong clinical knowledge which you require to diagnose syndrome. And please remember that this is an emergency. So every person who has completed MBBS has to know certain emergency conditions, and in orthopedics, one such important emergency or syndrome. Yeah, pain on passive stretch is there, but that is also not such confirmatory, right? When your suspicion and if that is present, you can think of compartment, right? So now what happens? So why are we worried? What happens if this complete blood flow stops and the vicious cycle it is going? So what is the sequel of it? So once what happens, if you don't control this vicious cycle, the muscle which is going, it goes into, the muscle goes into necrosis, and it will finally result in what is called as fibrous tissue. Now the muscle becomes dead, muscle becomes necrosed, and this is replaced by your fibrous tissue. So this replacement of fibrous tissue will result in certain fractures. Okay, so that could be in the forearm. One of the dreadful complication is Volkmann's ischemic contracture. Volkmann's ischemic contracture. It can lead up to that level, right? So whenever there is fibrous tissue, so now muscle gets died and this is replaced by fibrous tissue. It is not like bone healing muscle. Once it is damaged, it will not be replaced by muscle again. It becomes dead and it is replaced by the fibrous tissue, and now this becomes completely contracted, which will result in contractures, right? And sometimes if the blood supply is gone completely, that may also result in what is called as gangrene, and it will result in amputation. These are all the complications of right? So it may result in contractures or it may result in gangrenes, and it will ultimately amputation. So these are very, very dreadful scenarios. So this can be just to be replaced. All this can be avoided by your clinical knowledge. So that is where doctor is treated as God almost, right? So we are just trying that we are just trying to help the patient not to land up in contractures, gangrene, and amputation, right? So that this is very, very important. So one such thing which you have to be is suspicion. And now you have to know when to suspect. Actually, if I go and say suspect, you can't suspect in every case, right? So what are those important causes? So first, whenever there is fracture in certain areas, such as your forearm fractures and leg fractures. So these two are very, very notorious where we can expect. And in case of burns and in case of tight structures such as casing, your slab application, and post-operative, and certain fractures such as your supracondylar fractures in children. So these are certain causes where you can, you can expect compartment syndrome to occur. So you have to be very, very careful. And now what you do first in the exam, you will write what is the osseous facial compartment, and then this is the causes. You write what are the causes where you have to suspect. Huh. Open tibia compartment syndrome is very rare because it is open, right? There will be breach and everything is open almost there. So it is little more not very usual, open, but closed. Yes, closed again compartment syndrome. And now you will write this vicious cycle. So this cycle diagram you have to draw in the exam because the exam is searching for the cycle whenever they ask about compartment syndrome. Even if you write all these or not write, if you draw this diagram, that is fine. So where will we start the vicious cycle? There will be trauma. So this can be any amount of trauma or tightness. This can occur. This will lead into what is called as slight amount of because of the trauma. And what happens is because of this ischemia, there will be a pathology which happens, which increases the capillary permeability that will result in edema. So main important what you have to remember is this muscle ischemia will result in this edema. So I've told you, right, this ischemia will result in edema. So how is this happening? This is because there is an histamine release and that will cause the increased capillary permeability. So it will draw more and more of water and now this will result in edema. And this edema, whenever there is there, I've told the volume that is putting more of volume into the compartment. So once the volume is stabilized, I mean, it's saturated, it will cause increase the pressure. So whenever there is increase in the pressure, there will be again differences in the flow of the blood. So that will result again in or spasm again because of lymphatic, all those obstructions will occur, all the capillaries will close. So this will result in artery occlusion or there will be loss of blood. So loss of blood supply, this will result in issue. Again, this whole cycle will repeat. So this is about the your vicious cycle, that is your compartment syndrome. So we have finished the definition, we have finished the pathology, we have finished the vicious cycle, which is very, very important, and the causes. Now I'll tell you the clinical signs and symptoms. As everybody know and very, very important, okay, the signs and symptoms as the Kalai has mentioned. So the first one will be pain. So we told there is an unexplained pain with increased analgesics. Also the patient will have severe pain. Then what will we have? He will have pain, pallor. Then, so the last one what you have to remember is pulselessness. So this is the last one to occur. You will not wait for this. Okay, and this is very, very important, and this pain on passive stretch is very, very important. So because the compartment, yeah, presence of pulse does not rule because that is the last one to occur. Sometimes what happens, initial days, in our residency 1 and 2, what we used to see the pulse, and because the pulse is present, we used to think there is no compartment syndrome. It's not like that. Pulselessness is the last one. So first one is pain and passive stretch. So whenever you feel that there is a tightness in the compartment and you still stretch it, right? Already it is tight and you will still stretch it, then there will be more pain. So that is the pain on passive stretch. So that is also very important thing for you to diagnose. So pain, pallor, then you have your paresthesias and paralysis. right? So these are the 5 P's. Okay, so this paresthesias and paralysis is because of your loss of nerve supply. So again, same strategy. So once there is a lot of pressure which is occurring there, and there will be paresthesias, they cause compression of that nerve. So there will be paresthesias. And remember, sometimes with the pain, the paresthesias also can occur early, right? So especially the forearms. So forearms, the paresthesias can also occur little early, right? And paralysis, the patient cannot move the limb. And finally, last one is pulseless. Okay, early is pain and paresthesias, failure to some extent, and then late is pulseless. Like that also you can divide. And what I have told you, the diagnosis, I mean like clinical diagnosis, and what you do is delta P. If it is more than 40 mm of Hg, where you can measure the pressure with certain instruments, so then you can confirm it as compartment. So these are certain diagnostic criteria for compartment syndrome. Finally, what is the treatment? Treatment is emergency. First, remove all the tight structures. You can elevate the limb, active finger movements for, mild cases. And finally, if it is an established case, for fasciotomy, fine. So the culprit is fascia. So why wait for just cut the fascias? So this has to done in all compartments. So if there is forearm only compartment you're doing, you're suspecting it, but you have to open all the compartments. So fibulectomy is one such surgery where you can release the pressure in all the three compartments. Fasciotomy and fibulectomy, these two are the management for your compartment syndrome. Okay, so we have done the causes, pathophysiology, the clinical features, management, and including. So management, they have, this is normal management, like you can measure the delta P and pain on passive stretch, and you can remove all the tight structures. But surgically, what you do is you do fasciotomy, because that is very, very important, and fibulectomy. Is that clear? Vikash Kumar, yeah, we will start paramedical kabhi class. We'll see. Guys, are you with me? Shall I thank you for that? What about the others? Okay. Yeah, mindful study sessions. Is it helping you, mindful study sessions? Okay. So the next important thing is Volkmann's ischemic contracture. So we have dealt with the compartment syndrome, fat embolism, very, very important. 10 marks I've told you. The next one is your Volkmann's ischemic contracture. This is also 10 marks. Here they're asking to explain about the etiology, the classification, the pathophysiology, the clinical features, and management strategies, right? So if you see, they have added the classification here. For compartment and fat embolism, there is no classification, right? So Volkmann's ischemia, there is a little small classification without the name. So let's see what is Volkmann's ischemic contracture. So we already know VIC is Volkmann's ischemic contracture. This is nothing but a sequelae of certain things. One is Volkmann's ischemia, and it could be sequelae of compartment syndrome. right? So what is Workman's ischemia? Hello, Ravikant. So this is a thing which is seen in supracondylar fracture. Supracondylar fracture where there is damage to the brachial artery. So whenever there is damage to the brachial artery, it will result in Volkmann's ischemia, which will ultimately result in what is called as Volkmann's ischemic contracture. And as I've told you again, in compartment syndrome also, there is a sequelae of this where the muscle undergoes fibrosis and will result in contractures. One such important contractures which can see in flexor compartment syndrome is Volkmann's ischemic contracture. Ravikant, I'm fine, thank you. How are you? So, etiology. So, coming to the etiology, so again, it is nothing but again same. Whatever, whenever there is a damage to the muscles which is replaced by the fibrous tissue, it will result in this contracture. So again, that is what is the etiology. The Workman's ischemia and compartment syndrome. And classification. When it comes to classification, you can somewhat write as mild, moderate, and severe. So this is a small classification. Mild is where only this small amount of finger contractures are there. Moderate is both fingers and wrist is contracted. Severe is where there is bone changes also present. Very, very, not very important, but clinical classification. Mild is only mild involvement of the structures, and moderate is where you see the wrist and the finger flexion. Yes, correct. Mindful study session. Yeah, it is an emergency. You have to refer to the surgeon, right? And severe is bony changes where completely there is loss of, or you can add as nerve is involved. I'm actually happy that you're listening to the class. So that's it, guys. So first is definition. So the etiology and the definition is the same. So we know already it is a consequence of the some important complication as well. That is compartment syndrome itself is a complication. So this is sequel of that complication. Volkmann's ischemia is a brachial artery injury where again it is a complication and it is a sequel of this, and this is a very dreadful sequel. So you have to be very careful. Again, Volkmann's ischemic fracture is a dreadful right? And classification, we have dealt it as mild, moderate, and severe. Now let us see the pathophysiology. The pathophysiology is again, as we all know, the muscle becomes dead, or you say necrosis happen to the muscle because of no vascular supply, and this ultimately will result in fibrous tissue. That this will result flexion, that is the flexor compartment is involved, so it causes complete flexion like the Workman's, right? So something like that. So whole muscle replaced by fibrous tissue. Muscle, whenever it is present, what is the action of the muscle? It contracts and relaxes, right? It contracts and relaxes. So it contracts and relaxes. But when this muscle is replaced by a fibrous tissue, what happens is all of this fibrous tissue, it can contract, it cannot relax, right? So because of this contraction, completely it goes, the wrist goes into flexion, fingers go into flexion, right? So this is the forearm, what I'm talking about. This is the forearm VIC, right? The forearm VIC, right? So these fingers like this, they go into flexion. So here what you have to remember is one of the important sign which is called as the Volkmann's. So what is this Volkmann sign? Volkmann sign is whenever you tend to flex the wrist, because of that tension, what happens is the fingers get relaxed. And whenever you go wrist into extension, because of the pull, the fingers go into flexion. Fingers now go into flexion like this. On wrist extension, on wrist flexion, they become relaxed, and now you can see the fingers get extended. So this is the Volkmann sign. So this presence of the Volkmann sign also tells you that the patient is having Volkmann's ischemic contracture, right? So that is about the Volkmann's ischemic contracture. And now, so that is the pathogenesis clinical feature. And management strategies, what you have to remember is whenever it is just a mild deformity, you can treat with the Volkmann's splint. Volkmann's splint, it is also called as turn or buckle splint. So we put this splint so that all the things whichever are flexed now gets relaxed with this Volkmann splint. So that is for mild deformity where you encourage. If it is a moderate deformity, you go for max page sliding operation. That is soft tissue sliding operation. What we do is relax the flexor muscles from the origin so that they have certain movement which can, right? And if it is severe, you go for bone injuries, because whenever there is involvement or changes in the bone, it is called severe deformity. So you can go for what is called as bone shortening or carpal excision. Carpal bone excision or bone shortening. Why all this we are doing? Because we want to decrease the length of that thing. So contracture is something which is a tight structure, so you want to make it loose, right? So soft tissue sliding operations also will release the flexor so that they become loose. And severe deformity also, the bone, whatever the bone is making it to be, stretched, will take small amount of bone so that now the whatever the tissue is there, that becomes relaxed. Now it goes into extension. The flexion now goes into extension. That's it. So this is about the Volkmann's ischemic contracture. What you have to remember is first the etiology, then the classification, then the pathophysiology. Pathophysiology is same. So you know that it is again because of the fibrous tissue, right? The fibrous tissue has no action. Like it cannot relax, it cannot contract. It is just pulling nature. So this pulling nature is released. That is by certain surgeries, right? And what is main important is the Volkmann's sign. Volkmann's sign is usually seen in the hand where the fingers go and wrist inflection. So on further flexion of the wrist, the fingers get relaxed, and extension of the wrist, the fingers get flexed like the Volkmann's, right? And then what is the treatment of it? Treatment, you have to remember, again, passive stretching, that is the Volkmann splint. Moderate deformity is your soft tissue sliding operation, and severe deformity, you go for bone surgeries or bone extension. Is it fine? That is VIC. So mostly you have to remember the causes. It can be seen in supracondylar, that is because of the brachial artery injury or a sequelae of your compartment syndrome. So now that completes important fracture complications, and then we are dealing with the important fractures. So one such important fracture which you have to remember is your supracondylar fracture humerus. So this is the supracondylar fracture humerus, and then he is asking the causes, the clinical features, the classification, the complications, and the, so any fracture from now here onwards, if they ask you about individual fractures, you will always start with the definition again. So definition is where the fracture has again occur and why it is called so and so fracture. That is the definition. Then you will write the causes, or instead of causes, you can write the mechanism of injury. So how is the fracture occurring? So that is the mechanism of injury. Then how the patient presents. So that is the signs and symptoms. So signs and symptoms where you see of that particular features, that is the clinical features you're going to discuss, right? And then management. So before that, you can put it as diagnosis. So diagnosis, what you do, you first take an X-ray for any fracture. X-ray is important. Then you write the classification, right? So classification. Then you write the classification, and then you will write how do you manage the case. That is, do all nerves heal themselves? I mean, this healing of nerves is in the VIC or where? So nerve healing is again a separate entity where there is neuropraxia. That means if there is only small injury or mild injury to the nerve, it will heal. Yeah. But if it is axonotemesis or neurotemesis, then it will not heal. So this is what is the proforma, guys. You have to remember this. So first you will always put up the definition for that particular fracture. Then you will tell the mechanism of the injury of that particular. How does it happen, right? And then you will tell the symptoms and the signs of that. So that is nothing but your clinical features. You can add certain tests also if you have clinical features. And diagnosis is X-ray. Specifically, you will write the X-ray. If this an MRI is needed, you will write that. And on the X-ray, you will put up the classification. Then you will write the management. We are going to fracture. So first coming to the supracondylar, we are dealing with the supracondylar. And finally, not to forget, as I forgot, you have to end with complications. Very, very important. Complications. So this is the complication, right? So this is the proform of anything, any fracture. So now we are going to write about the supracondylar fracture. So in case of supracondylar fracture, first definition what you're going to write is usually seen in age group of 4 to 8 years, and this is seen in the distal humerus, right? It is seen in the distal humerus above the condyle. Above the condyle. So if you think these are the two condyles, so this is the area of the supracondyle. This is the supracondylar fracture. And whenever you mention about supracondylar fracture, so you know that it is usually a pediatric fracture and usually occurs in 4 to 8 years. And it is mainly the cortico-cancellous junction to some extent. And that is the age, that 4 to 8 years of age, right? So that is why it is very, very common. And usually, yeah, pusha, fallen outstretched hand. Okay, it is also a type of Fuchs injury, as Kalai told us. Injury, yeah. So this is the main thing. The definition is mainly you have to mention that it is above the condyles. So this is the injury of pediatrics, pediatric age group 4 to 5 years, usually above the condyles. And now what happens is it is usually as a result of fall of outstretched, fall of out. And now coming to the classification. So now coming to the classification, it is very, very easy. So there are two types. One is your flexion type and second one is your extension type. Which is most common? Flexion or extension? Faster, which is common? Flexion or extension type? Yes, very good. Extension type is very common. 80% are extension, 20% is flexion. Right? So how do you tell this is flexion or extension? Which one is flexion? Which one is extension? This is A, this is B. So now going back to fractures. So this is a fracture, right? So this is a fracture which has occurred. So this fracture now is result, it is undisplaced fracture or displaced. Yeah, Gartland classification is okay. Flexion and extension, that is supracondylar is Gartland's classification. Now which one is flexion, which one is extension? A is what, B is what? So now based upon our theory, that is classification of fractures, is this is a displaced fracture, right? A is flexion, B is extension. Jitendra, first of all, how will you decide the displacement? Based upon which fragment? Now I tell you, this is your proximal fragment, this is your distal fragment. You can see this is first fragment, this is second fragment, right? So which is proximal and distal? The displacement of the fracture is decided by which fragment? Proximal fragment or distal fragment? Proximal is near to the head. Distal is away from the head. Yes, Kala is right. A is extension, B is flexion. So, distal fragment you told no, Jitendra, distal fragment is this no. Now this has gone into extension, right? This is going into flexion, right? Yes. A is not. A is extension. B is flexion. Understood? So whenever there is a fracture, whenever there is, this is long bone if you think, and now there is a fracture. So these two are now displaced. So this displacement is mainly decided by the fragment which is away from the head. This is proximal fragment which is near to the head. This is away from the head. So movement of this, it is moving medial, medial displacement. It is moving lateral, lateral displacement, proximal, proximal displacement. It is moving on the lateral X-ray. If you see, it is moving dorsal, dorsal displacement, ventral displacement, like that. So based upon the movement of the distal fragment only, you have to decide the displacement. So here what happened, this has gone into extension, right? So here the distal fragment is going into extension. See, this also you can make out. So this is extension. Now this is going into flexion. That means this is coming anteriorly, right? This is going posteriorly, right? So that is the displacement. Now the most common type is that is going posteriorly or distally. That is the extension. That is 80%. Very, very important. Once you're talking about supracondylar fracture, they usually expect you to write this, right? Even if you write Gartland classification or not, also they won't feel bad. But you have to write most common is extension. So what you do, you know this is important point, right? So you will put two star marks or you will underline it. Get more. Okay. Focus should be only on getting more marks. Then only you will get. So this is again similarly in AP view. If you see this is the displacement, right? So it is displacing medially or laterally. You can tell on the AP view, and lateral view you can tell it is displacing anteriorly or posterior, right? Or it is an extension or flexion. So that is the classification of the supracondylar fracture. And now you have to talk about the displacements. As I've told you, so this supracondylar fracture can displace anyway, wherever it likes, it can displace. So it can go medially, it can go proximally, right? And as we all know, it can go posteriorly. So these are the displacement. Based upon the displacement, why you want to know this displacement? Because whenever you understand the displacement, then you can reduce the fracture, right? So you can reduce the fracture. Now what is the most important thing which you have to remember in supracondylar fracture is, so whenever it is like this, on the anterior aspect, if you see, there is one important artery which is going like this. So what is this important artery? So whenever we talk about the supracondylar fracture, the first thing we talk it is a pediatric fracture. The second thing we talk the displacements, which is very, very important. And in case of extension, we talk about this a very important complication. And as soon as in the emergency or casualty, yes, very good, emergency or casualty, if you aspect. If it is a supracondylar fracture, you have to immediately check for the, when you know this is a radial, when you know this is a brachial artery, where do you check for it? So you're going to check for the radial artery pulsation. So this is the thing what they expect from you whenever they talk about the supracondylar fracture. So what is the first thing? Clinical signs and symptoms. So we are done. What we are done with? We are done with the causes. Causes is again nothing. You have to fall down. Trauma. There will be clinical features. So clinical features. So clinical features. What will happen is first they come with swelling and pain. Right. So immediately what you do? You check for the which pulse? Radial pulse. So these are the important things which you have to remember in case of certain important fractures. It is not like every fracture you write the same. So whenever you're writing supracondylar fracture classification, you will write flexion and extension guideline classification where you mention that this is most common type. And again, you will draw this particular diagram and say that there will be kinking of the brachial artery. Hence, as soon as the patient arrives, you have to check for the radial pulsation, right? And patient, usually because it is a fracture, you will have swelling, you will have pain, you will have deformity, and she will not allow you to touch. Now what happens? Yes, very good. So on examination, if you want to confirm it as your supracondylar fracture, then you check for the 3-point bony relationship. So in this, what happens is the 3-point bony relationship is maintained because it is above the condyles, right? The condyles are not yet disturbed. So this 3-point bony relationship is still maintained in case of the supracondylar fracture humerus. And again, what you do, you know this is very important. So again, you put a star mark and you underline it. So whenever you see for this such an important underlying points, it will be very easy for the examiner to assist you, right? So this is the 3-point bony tenderness which is maintained. Now what you do, you send the patient for the x-ray, and the x-ray you confirm the diagnosis, right? Confirm the diagnosis. On the x-ray, what do you check? What do you check for the x-ray? Check whether this is an displaced or undisplaced. If it is displaced, what is the displacement? Are you dealing with the extension type, or are you dealing with the flexion type? Are you dealing with the medial displacement or lateral displacement in case of the x-ray? On the in this particular patient, right? So you will confirm the diagnosis on the x-ray. And now you have to be very careful if the pulses are absent, right? And again, you have to remember that this is also a mini type of emergency. Okay, so whenever there is supracondylar fracture, first we, so you are happy the pulse is present, unhappy the pulse is absent. But remember, this presence or absence of pulse will not convert the treatment. So here you will try closed reduction. Here also closed reduction, right? Here displays. That is very important. Okay. If undisplaced, now you should immediately ask me if it is undisplaced, then what you do? See? Right? If it is undisplaced. But if it is displaced with the pulses present or with the pulses absent, you will first try for closed reduction, and you will, if reduced, you go for KYR. then tab for 3, right? If in close reduction pulses are not there, will wait for 1, okay? You will wait for 1 hour. Yes, yes. X-ray is very, very important. Pulse there, pulse not there. You have to get an X-ray, because on the X-ray you will understand what type of fracture it is. How to reduce, you have to know whether the maneuver is only extension type maneuver or the flexion maneuver. That depends upon the X-ray. So pulse is there or not there, X-ray is compulsory, right? So now what happened in close reduction also, you will wait for 1 hour, and if recovers, then you will follow the same protocol. If no recovery, then go for open reduction and fix, right? So this is about very, very important supracondylar fracture. So you have to remember this. If you remember this, that it is done, nothing to deal with supracondylar, right? So first thing what you have to remember is this is a pediatric fracture. It is commonly seen in 4 to 8 years. Push injury, as we all discussed. The classification is guideline, flexion and extension. You will write extension is the most common, right? And then what is the most important thing on clinical examination is checking for the radial pulse. After radial pulse is checked, then you have to also check for nerve injury. Nerve injury is also very, very important. Nerve injury also you have to check, right? So you know anterior, median, radial, ulnar, right? So AMRU is the it is the mnemonic which you have to remember. So most commonly damaged is your AIN, anterior interosseous nerve, then comes your median nerve, then comes your radial nerve. So this depends upon the displacement, right? If it is lateral displacement, radial nerve will get involved. If it is a medial displacement, ulnar will get involved that way, right? So this is what is very, very important, okay? So supracondylar fracture, first there is a fracture, you will see whether it is pulse present or not. Once the pulse is present or not, you go for X-ray, and based upon the X-ray you see whether you have to reduce it. Both the close reductions only you will do. There is nothing like if pulse is not there, directly go for open reduction. It is not the criteria. This is the X-ray. So this is the X-ray. You see now the distal fragment is towards the lateral side, right? Lateral side it has moved, medial side, right? Again, this is going anteriorly and this is in the extension, right? So this is the supracondylar fracture. Yeah, AIN is more than median, correct. So this is the thing. So now once closely reduced, you have to, if reduced and you're satisfied with the reduction, then you can fix it with the K wires. Then you have to apply slab for 3, right? If it is an undisplaced fracture, there is no displacement at all, then you can directly put this slab, right? And if there is a pulse which is not there, and now what you have to do, you will do close reduction, but you wait for 1 hour and check the pulse. If the patient recovers, then it is same. You go for, if it is reduced properly and pulses have returned, then you put the KYS, then slab. If there is no recovery at all, then you go for open reduction. So what is open reduction? What is closed reduction? Open reduction means you open the fracture site, right? Closed reduction is we don't open the fractures. And now when we open it, we fix it properly, and then also we fix the art, right? So now what is the maneuver of the close reduction? What is the maneuver of the close reduction? So whenever the patient is having a supracondylar fracture, right, you have to be very careful. You have to be very careful, because once, even after reduction also, the pulses might get absent, because the brachial artery is just anterior to it, right? So first and foremost is always traction which you give. And now what you do, you flex in traction, right? So slowly you flex it, so you drag it like that, so it is clearly seen in. So this is the assistant who is holding the arm, and now the surgeon holds the forearm, I mean exactly near the wrist, and he gives traction. This is traction. Right? First, you disengage the fragments. Traction for is for what? Is to disengage. So fragments are like that, no? So you will disengage the fragments. And now what you do? You slightly flex. While flexing, you milk this component. Like we already know that it has gone on the posterior side. So from the posterior side, we are trying to push it to the anterior. So once that pushing is done and it sits properly in its position, you will be able to flex it to 90 degrees. So this is the indication for you that the reduction is done properly. So you can happily flex it to 90 degrees. And throughout this maneuver, you should monitor the radial pulse. Sometimes even if you not get complete 90 degrees flexion, but sometimes, after going to 90, the pulse will be absent, and to some angle the pulse will be present, so you can immobilize the patient to that angle only. Right? It is not that compulsory you have to go to 90 degrees, but going to 90 degrees, and if the pulse is still present, it is a very good technique. Right? Hope you understood. So that is the steps in reduction of the maneuver. You can just put it as, management. I mean, like treatment, you can just write it like you reduce it by giving a traction, then flexion, maintaining the flexion, reduce the distal fragment. Now immobilize in 90 degrees. So once you do this 90 degrees, no, what happens is you will check under the CM, that is in the operation theater, and if the reduction is good, then you go for K wires fixation. So you put 2 or 3 K wires like this. So these are the K wires. So these are put like this, okay, through the fracture. So this is the fracture. We have reduced and we have put 2 K wires. So this will maintain the fracture. And once the fracture is maintained well, you put this slab. So this slab is an above elbow slab. You put it for 3. And the protocol is you have to take X-ray 1 week, right, and check for the displacement. So that is the treatment. So you can, K wires is very, very important, and checking of the X-ray is also very, very important for 1 week. And having said and done all these things, the most important thing is complications. So we have understood so much of the supracondylar fracture, but still we may land up in complications. So first, the early complication, the late complications. So what are the late complications, early complications? So once we know that is the injury to the brachial artery or injury to the median nerve, right? And this brachial artery injury might result in Volkmann's issue, right? So this is the complication. And then late, okay, this can result in VIC, that is Volkmann's ischemic contracture, and this might result in what is called as malunion, and this is called as vitus. This is one of the most important complications which you have to remember. So one is your cubitus varus, that is malunion, and this is your gun stock deformity. Okay, very, very important question. Gun stock deformity. What is gun stock deformity? It is a complication of supracondylar fracture, complication of the supracondylar fracture, which will result in cubitus varus, that is your gun stock deformity. Okay, clear guys? So this is in detail for your supracondylar fracture, right? Yeah, gun stock deformity, the treatment of gun stock is again your osteotomy. Any deformity is osteotomy, right? So one more important late complication which you have, which might occur, is myositis ossificans. What is myositis ossificans? Yeah. So you massage over that area. and that will result in formation of bone in the elbow joint. So that is your myositis ossificans. So this is about the supracondylar humerus. So we are done with everything. So we have done the clinical features, the classification, the complication, early and late, and then the management. So management, you know that we are going to deal with the reduction, and when we are going to put the K wires, and for your complication of malunion, the management would be osteotomy. Osteotomy. And then there is myositis ossificans. This is excision. The treatment of this is excision. And VIC treatment we have learned in detail. Yeah, this is metaplasia. The myositis ossificans is the brachialis muscles which is present, no, that will undergo transformation. So the myocyte will become osteocyte and will become formation of bone. So what actually happens in myositis ossificans? The elbow stiffness. The patient will come with elbow stiffness. And on the X-ray, you see there is bone which is formed in the joint, and that is called as myositis ossificans, right? The treatment of myositis is excision. The treatment of BIC we are dealt, and the treatment of cubitus varus is okay. Myositis ossificans is nothing but myositis ossificans. That means muscle is getting ossified. Usually, what should ossify? Bone should ossify. But here, the muscle is getting ossified. Why? Because there are certain things which will happen to it. That is usually when you go to the osteopath. So, in case of supracondylar fracture, usually the fracture is here, right? What the osteopath do is they do a lot of massage in that area. This massage maneuver will stimulate the muscle brachialis. So this brachialis muscle, what happens? So the stimulation, it will convert itself not into a muscle but into osteocyte. So this osteocyte starts laying the bone. Where it lays the bone? In the elbow joint. So there is a bone formation in the elbow joint. In the elbow joint. So whenever there is something bone in the joint, what will it cause? It causes stiffness, right? So whenever you do active passive movements, both the movements are restricted. So now the patient comes to you telling that, ma'am, is I'm unable to flex my elbow completely. And then you will try, because passively sometimes we can do, but passive also you can't flex. Then you will realize that there is some problem in the joint, and you get an X-ray. On the X-ray, you see the elbow joint, there will be bone formation. So that is how you confirm the diagnosis of myositis ossificans. It, you have to cut open the joint and you have to excise complete joint. Like not the joint, the bone, the complete bone which is formed, you have to excise the bone, right? That is the treatment of your myositis ossificans. Is that clear, Jitendra? But yeah, is that clear? Yes or no? Oh, we have covered everything, no? Supracondylar, anything I've left out? Yeah. So now next comes the sister of supracondylar fracture, that is the lateral condylar fracture. So good. So sister of the supracondylar is lateral condylar. So coming to the lateral condylar, I'll tell you what are its specific features. So late supracondylar, what I have told you, it is above the condyles, right? But when it comes to lateral condylar fracture, it is intercondylar fracture. That means in between two condyles of the humerus. It is intercondylar fracture. It is going upwards, right? The fracture extend upwards. Yes, massages are not encouraged hereby. Okay, no massage. So here you see the fracture is oblique and it is extending upwards, right? It is extending upwards. So this is your lateral condyle. So what are, I'll tell you the specific characters, you know, not everything in detail. What I have to want to tell you is this is the lateral condyle. know this. So what are the components involved in it? So there is a capitulum. The structure capitulum is involved plus lateral condyle, and you can see there is a common extensor origin, right? So there is a muscle pull which is there here. So this is the common extensor origin which is there, and now because of this pulling of that, origin, the muscle which is pulling, this fragment gets displaced. Sometimes it gets 90% displaced, so it is like this. So it gets displaced, that means it gets rotated. So this is the displacement, this is the displacement. So because of that pull, the lateral condyle, the fragment gets displaced. So now this will lead into, when the fragments are not together, what will happen? And not to tell you that this is a intra-articular fracture. So what is the complication you expect whenever you see the x-ray of your uh, intercondylar fracture or this lateral condyle fracture? So supracondylar fracture, whenever you see the x-ray, you know what to look for. You look for radial pulse, then you know that tell them not to massage, then you tell them, cubitus varus can occur. Then in for lateral condylar, what is one important complication which you tell the patient as soon as you see the x-ray? Faster. Yes, it is Salter Harris type 4 because it is through, right? It involves the meta, the epi, and the physis. So whenever all the three are involved, it is Salter Harris. That means it is involving the growth plate. Pediatric fracture classification, it is involving the growth plate, and Salter Harris type 4. Very good. Yes, it is non-union. So whenever you deal with an intra-articular fracture and the fragments have been displaced broadly, you have to explain the patient that you might land up with an important complication that is non-union, and this might result in a deformity which is called as cubitus valgus, because the lateral side the growth is stopped and the medial side the growth increases further, which will result in what is called as cubitus valgus. Okay, so that is the definition of an important points of lateral condyle. So they ask you about lateral condyle, you have to tell. So definition of lateral condyle is, it is a intercondylar fracture which is oblique and moving upwards. It is an intra-articular fracture and it is a pediatric growth plate involving fracture. So it is Salter Harris type 4. Right? So this is the definition. Then they will ask you the clinical features. So clinical features are the same, right? You will tell that there is a swelling which is present, and then there is a pain which is present. The patient will be unable to flex or extend. The movements are painful, right? And on the x-ray you see that there is an lateral displacement. But what you have to understand is, because of the cartilage, the fragment appears smaller on the x-ray. The x-ray, right? So this is the one thing which you have to remember in case of your lateral condyle, because the cartilage is more and the bone is minimum. Look, I'm not pretty sure about the guidelines of taking surgical and medical branches. Just check and let you know. But that also depends upon what type of problem you're facing with, right? Right? Is it a systemic problem that might involve your other vision, or it is just, there are various issues to address. So that is it. On the X-ray, you see that the cartilage fragment appears smaller on the X-ray. So you have to be little careful in the lateral condylar fracture, and you see the displacement of that particular fragment, because I've told you that this particular fragment attachment will result in non. And it keeps putting the flexor the extensor tendons keep pulling the fragment, right? So that is about the important clinical features and the X-ray. And how do you manage? So here the thing is, because it is an intra-articular fracture, which is happening there, you have to have what type of reduction? This I want you all to answer. So this is an intra-articular fracture. Tell me what type of reduction you need and what type of stability you need. You should only answer this. Faster, faster. We're running short of time. It is already 8:30. Yes, we have to go for open reduction and internal fixation. And what is that stability which I have told you? Jitu, what is the stability I told you? Yeah, open reduction, internal fixation will give what type of stability to this? What type of reduction? What type of healing? You have to answer it. Absolute reduction. I told you, no, absolute stability, anatomical reduction. So what happens is, whenever we are intra-articular fracture, we are dealing, you have to always open this. Yes, rigid fixation. You have to go for a rigid fixation, not a relative stability. You have to go for absolute stability for this particular intra-articular fracture. Again, what is the treatment? You treat it with the K wires only, right? Because it is an intra-articular fracture. You have to open the fracture. You have to fix the fragments carefully so that they go for absolute reduction. Okay. So this is the X-ray, as I've mentioned. This is the X-ray. So this is the lateral condylar fragment, capitulum and the lateral condyle. And because of this tendon, which is yeah, primary healing, correct. Because of the tendon, it can rotate even up to 90 degrees, right? So this is the X-ray of the lateral condyle. And in the lateral condyle, what one expects is the complications. You have to be very careful about the complications, because it is one thing which is intra-articular will make it non-union because of the synovial fluid inhibitory factors, and then this can result in what is called as cubitus valgus, right? And it can result, because the joint is involved, there will be osteoarthritis. And one more important thing is, yes, tardy ulnar nerve palsy. So this sequelae of cubitus varus is your tardy ulnar nerve palsy, right? Tardy is late. So because of the lateral side, the growth stops. Medial side, the growth keeps increasing. So now what happens? This will result in cubitus valgus. So this valgus, whenever is having, which causes the stretching of the medial nerve. It causes the stretching of the ulnar nerve, because the medial side has increased more, right? So this causes stretching and will result in tardy ulnar palsy. So what is the sequelae of ulnar palsy? What the patient presents with? He presents with gnawing, gnawing of the hand. So this could be a potential, case for the viva for you in the practical examination. So they tell you that the patient is having claw hand, and when you dig into the history, he will tell you that in past he has the lateral condylar fracture, which has resulted in the tardy ulnar palsy. Yeah. Yes, partial clawing of the hand. So this is about your lateral condylar fracture, right? So we have completed supracondylar and lateral condylar, and now coming to the most important, that is your Colles fracture. Yeah, claw hand is correct. Yes, hypothenar atrophy and claw hand. Yeah, Klumpke's hand, or that is also involvement of lower trunk, gait and T1. That is also partial claw. So now coming to the Colles fracture. So as I have told you, again starting with the definition of your Colles fracture. So what is the definition of your Colles fracture? This is very, very important. Definition of the Colles fracture is, it is a fracture which is usually seen in osteoporotic females, fracture of distal radius 2 centimeters away from the joint in the cortico-cancellous junction of radius, right? Very good. And most important is, it is an extra articular. Okay, most important is the extra articular fracture, right? And not to forget with dorsal displacement. Only dorsal displacement. There are certain varieties of the displacement which you have to write. So first one is impaction, dorsal displacement as I have mentioned. Then comes the dorsal tilt, then lateral displacement, lateral tilt, supination. So whenever you want to talk about your distal radius, associated ulnar styloid fracture, it could be, yeah, associated with the ulnar styloid process. Not a definition, it's an association, right? So these are all the displacements which you have to remember. So whenever there is an extra articular fracture of the distal radius, okay. And now what I mean by extra articular? What I mean by extra articular? Extra articular means it is not involving the joint. There is no joint which is involved. And what is for most important point? So this is the most important point. The fragment displacement. In supracondylar, we have learned that it goes extension and flexion, right? So here it goes dorsally and laterally, right? So if you see, this is the X-ray AP view. This is the lateral view, right? In the AP view, what happens? This is an extra articular. Extra articular matlab from the joint, it is away. At least 2 centimeters away from the joint, not involving the articular surface. So one important point. And on the lateral X-ray, you see that the fragment. So usually, anatomically, the distal articular surface, the distal radius articular surface is medially and ventrally oriented. I mean, in the normal X-ray, in the normal anatomy, in the normal bone. But now, whenever it becomes laterally, whenever it becomes dorsally, that means there is some fracture which has happened. Right? So these are all the shifts which can occur. So there will be radial shift, radial tilt. That means lateral side it moves, right? On the AP view. On the on the lateral view, it is dorsal tilt or dorsal shift. Even if it is neutral also, it is fracture. It has to be ventral. The articular surface has to be ventral normally. Even if it is from ventral to normal, that is neutral also, it is a fracture. If it is dorsally, then it is confirmed fracture. Yeah, it can be done closer. So this is the thing. So this is the normal anatomy. This particular diagram I have bought. So this faces ventrally and this faces medially. So medially and ventrally is the uh, orientation of the distal articular surface. So this is the radius articular surface, right? And now what happens is the radial styloid process is 1 centimeter proximal, distal, 1 centimeter distal. That means here is the radial styloid, the ulna is below, proximal, ulna is proximal. So this is like the ulta picture. We have put like this, right? So this is 1 centimeter distal. So it is up high, 1 centimeter higher compared to the ulnar styloid. And normally the distal articular surface of the radius is ventrally and medially. Now in the Colles fracture, what happens is it becomes dorsal, laterally and dorsal. So that is the Colles fracture. So this is the definition of the Colles fracture. It is usually seen extraarticular, 65 years old female mainly, osteoporosis is involved, and the dorsal displacement very important. What are the other displacements which we can see? That is impaction, dorsal tilt, lateral tilt, lateral displacement, and supination. And it is sometimes associated with the ulnar styloid process or with the or any other, the ulnar joint, inferior radio ulnar joint, or the TFCC, that is triangular fibrocartilage, which is present on the side. So this is all the associations which can occur, right? So that is about the classification. And then the mechanism. What is the mechanism of injury? It is again fall on outstretched hand, and usually the patient comes with slip, trivial trauma, or low velocity slip and fall in the house, which result in the distal radius fracture, right? And then what they have asked, so we have done mechanism. Yeah, clinical features, very important, right? What is the clinical features you see? So first there will be pain. So in ortho you can write pain, swelling, deformity in all the cases, right? But to get more marks, what is the deformity you see? It is the dinner fork deformity. One thing, not to jump to the conclusion, that is not the malunion, it is dinner fork. I'm telling even the fresh fracture also, because of the displacement which is there, dorsal displacement of the fragment, you can still see that there is a swelling on the dorsal aspect. So that will appear as dinner fork deformity. So pain, swelling, deformity can be seen, clinical features. And how do you treat it? Treatment is very important. So management, you get the x-ray, you confirm the x-ray, you see that this is an extra articular fracture on the x-ray, and then you attempt for post reduction, right? And then you treat with what is called as Colles cast, right? Yeah, how do you reduce it? So again, what are the maneuver you do? Very important. This maneuver, if you write, you will get full marks. So what is that maneuver? Always the assistant will hold the arm right at the elbow, and now the surgeon will hold as if he's shaking the hand. Hello, taking the hand like this, so you will hold it that way. So now what you do on holding that, you give mild traction to it. So this traction, whenever we give, that means we are disengaging the frame, and now we try to engage it in our way. So how do we do it? So here what we do, we take that particular fragment to palmar flexion and ulnar deviation, right? Because the fragment is on dorsal aspect, right? So slowly with the thumb, the surgeon presses his hands dorsally and convert that fragment into flexion and ulnar deviation. So that pressing will correct the dorsal tilt, and this will correct the radial tilt. So we give pressure on the lateral side and the dorsal. And now we will put the limb in palmar flexion and ulnar deviation. Obviously pronation only, right? So this is called the Colles cast. So how do you identify the Colles cast compared to the scaphoid cast? Here the thumb is free. So in case of scaphoid cast, you will enclose the thumb also. In case of Colles cast, the thumb is free, and this way is very important. Palmar flexion and ulnar deviation. So whenever you're writing, yeah, handshaking cast also you can tell, okay. So whenever you're writing the answer, so you will first write the definition, then you write about the displacements, and then you write about the pathogenesis, that is because of the push or slip, and then you write about clinical features, that is pain, swelling, and deformity can be present. And how do you do it? You do for a closed reduction. And sometimes if it is not reduced properly, other interventions you have to mention. So what are the other interventions? So you can go for K-wire fixation, right? And then you can go for external fixation, or sometimes plating, right? So Colles fracture, what is, yeah, scaffold is glass holding cast, very good. So what do? You go for plating, or this is K-wire, that is percutaneous, you go. Means you go from the skin only. You will not cut open the fracture, you can go from the skin directly, right? So that is about the fixation. So first is close reduction, that is conservative management. So here we are dealing about the conservative. Conservative is no surgery is required. So you go for Colles cast. But if the reduction is not maintained, you can go for K-wire fixation, or you go for external. So what you do external fixation is, after correcting the reduction, if it is still not holding, you put two pins in the first metacarpal, I mean second metacarpal, that is index, and in the radius. So these are the small pins which we put. These are the rods which we connect, right? So this is called as the external fixation. So now you tight all this with the rods and clamps. So here you connect with the rods and clamps, and when you tight all this, what happens is the ligaments will hold the fracture, and this is called as ligamentotax. So they can ask you as a 4 marks, what is a ligamentotaxis and where it is. Ligamentotaxis is a procedure, that is a surgical procedure where we take help of the various ligaments which are present around the wrist joint. So what we do, we put two pins in the second metacarpal, that is the index finger metacarpal and radius. So this is little away from the fracture, and then we tighten all these four rods, and when as we tighten, the ligaments get stretched. Now these ligaments, whenever they get stretched, they hold this fragment tightly. So this is called as ligamentotaxis, right? So that is about the K-wire fixation, ligamentotaxis, and plating. Plating, you can do it whenever the reduction is not proper. You want to reduce it, then you go, we use the ventral approach, right? So this side. That we open the fragment and then we fix it. That is about the fracture fixation, right? Then most important in Colles fracture is its complications. Its complications. So what are the complications which we see? First and foremost complication, it is finger stiffness. So whenever you put the patient in Colles cast, so even after K-wire also you will put casing. So cast is there even after K-wire, right? So this cast, whenever we put, this will result in what is called as finger stiffness. So finger stiffness can occur. Then we already know that malunion is one of the known complication of, right? And the third one is Sudex osteodystrophy. So Sudex osteodystrophy is a condition very painful to the patient as well as doctor, and this is a separate entity, right? So where the patient will have hyperesthesias, paresthesias, and skin becomes dry. So this is some sympathetic reaction which occurs, and this is called as Sudex osteodystrophy. And then there would be a rupture of your extensor tendon. Extensor tendon, EIP, extensor indicis, right? So this is also one of the important complication of these. Then you can result in what is called as osteoarthritis of wrist. Osteoarthritis of the wrist. So there will be osteoarthritis of the wrist, and they could land up in rupture of the extensor tendon, and they can be sudex osteodystrophy, and most important, I forgot, that is your carpal tunnel syndrome. And finally, they can land up in what is called as a subluxation of your inferior radioulnar joint. Fine. Okay, these are all the complications. This is also very, very important. Once you write the management, so you have to end the answer with the complication. So first is stiffness of the joints, mainly the finger stiffness, and then there will be malunion, as I've told you. This is very, very important. Right, and the carpal tunnel syndrome, because of the median nerve compression, can go to carpal tunnel syndrome, right? And then there will be compression because of the dorsal fragment, rubbing with each other. There will be rupture of the extensor pollicis tendon. Yeah, median nerve compression is Durkan's test. Durkan's test is not direct compression of the median nerve. So that is a test for your carpal tunnel. And finally, you have to remember that there will be subluxation of the inferior radioulnar, right? So these are the complications of the Colles fracture. Now, similarly, they can ask you about Smith's fracture. So what is a Smith's fracture? So I'll just conclude it in 2 lines. What is Smith fracture? Or this is also called as a reverse Colles. So whatever I have told you. Now, if this displacement is ventral, then that is your Smith fracture. So similarly, everything is similar in that. So this is the similar Smith fracture. So whenever, usually it is more common is Colles only. This is less common. So here you have garden spade deformity, right? Garden spade deformity. So here you have dinner fork deformity, here you have garden spade deformity, and here also you can try for close reduction, but the maneuver is different. And here also the complications are similar to the Colles, where it can lead to subluxation and of the inferior radioulnar joint, carpal tunnel syndrome, sudex astrophel rupture. Everything is similar. But what you have to remember is, in case of Smith's fracture, what happens is whatever the displacement I have told you, which is dorsal tilt and dorsal displacement, exactly opposite to it is reverse. That is, it goes ventrally. The whatever the ventral fragment which is facing, it goes still ventrally. So that is your Smith's fracture. So even if if they ask about reverse Colles fracture, you can write everything except for the displacements. Except for the displacements, you have to write there is a ventral displacement which occurs, and again the reduction maneuver is different. Not just the we now push the fragment upward, right? And again we put the cast here, and then we try for a closed reduction only, and we put the cast similar to the Colles, and then the complications are also similar, like the stiffness, the malunion, the subluxation, the carpal tunnel sudex osteodystrophy, and your extensor pollicis rupture. Everything is similar. Okay, that is about the Smith's fracture. Understood? Any doubts? Anatomy teacher. We have our Pradeep Pawar sir for anatomy in PW. So Mohammed Abdullah, you can try Pradeep Pawar sir's videos on YouTube. Okay. Are you guys tired? So much of ortho today. So we are coming to an end. We have fracture neck, and then I think we are done with that, and then posterior dislocation of 2 weeks. By probably by 9, 9, 10 we have to complete it. Fine. Any doubts? Anything you want to share? Should I continue? Any doubts? So next is very important topic, that is your fracture neck of femur. So this is very important that you usually ask you in the exam, your whatever any exam, Viva, and then your NEET, any exam. This is very important topic. So I want you all to concentrate better. Okay, fine. So now classify fracture neck of femur and discuss their causes, clinical presentation, complications, and management. Everything it is neatly given, right? Even if you forget, they're asking you to write everything. So before understanding what is neck of femur, you have to understand that the proximal femur is a very important thing because of the blood supply. So it has a head, neck, LT, and a shaft, right? So whenever there is a fracture neck of femur, so you have to differentiate between whether this is an IC fracture or a IT fracture, right? So in fracture neck of femur, we have two. One is IC fracture. The second one is IT fracture. So what is mean by IC and IT? IC is intracapsular. IT is intertrochanteric. That means I have told you that we have GT and LT. So whenever the fracture extends from GT to LT, it is intertrochanteric. मतलब क्या है? In between the trochanter. Whenever it is above the trochanters, it is intracapsular. Understood? So this is the basic difference you have to remember. This is the basic difference you have to remember. So if you remember where is the capsule attached, it is somewhere attached like this, right? Capsule is attached somewhere near the trochanteric crest. So you can simply tell the intertrochanteric as an extracapsular fracture, right? You can tell this as an extracapsular. So we have both intracapsular and extracapsular. So what is the basic difference? Why you want to differentiate between IC and IT? What happens when you treat it as same? Because the treatment between IC and intracapsular is where the head is involved, right? And because the head is involved, there is blood supply which is cut off, and this will result in avascular neck. So IC fracture, whenever you see, you have to put in your mind that this might result in AVN. Whereas in extracapsular, because the blood supply is intact here, this goes into, and this goes to N. Is that clear? So this is the basic difference which you have to understand. So whether they are asking about IC or IT or fracture neck of femur, this to remember. So if they ask you about IC fracture, point blood supply and displacement, which fracture? Jitu, I want your question to be more clear, more precise. Okay, this is mainly the differences of IC and IT fracture, guys. You have to remember these two important things. Now let us deal with the IC fracture. Now I'm dealing with the IC fracture. That is, so I've told you it is an intracapsular fracture. So it is happening inside the capsule, right? And it is usually seen above the age of 60 years or also below 60 years, right? And Trivial trauma above 60 for osteoporosis. High forces for below 60 years patient. Intratrochanteric, what happens? Joint split supply and displacement. Okay. Jitu, we will, I mean, like, once I complete everything, we will see. Okay. Okay. So now IC fracture, I have told you the differences between IC and IT. One is intercapsular, one is extracapsular. We are very sure. Intra is mainly what you have to put in mind is there will be some blood supply which is cut off because the supply is from the neck towards the head. So when there is a fracture of the this head goes into avian, right? So if you remember the blood supply from the anatomy of the first year, the blood supply is like this, something like this, the neck into head. So there is a fracture in the neck itself. So their blood supply. But for the intertrochanteric, it is not like that. There is the blood supply which is intact. This result, and this result, non-union. So coming to the IC fracture, it is an intracapsular fracture. So it is usually seen in than 60 years. And here what happens is clinical signs and symptoms. So patient comes with pain in the hip or groin. Sometimes in impacted. So usually pain in hip, unable to walk, right? But whenever it is an impacted, able to walk, but painful. So this is a very important condition which you have to remember, where the patient will have an impacted IC fracture. That means the IC fracture is there, but because of that contact, the patient can still bear weight and will come walk to the OPD. But she will complain only, she or he will complain only pain in the hip. Then you have to be very careful to identify this impacted IC fracture, right? And then what you have to remember, the classification of IC fracture is of three different classifications. So we have three different classifications. One is anatomical classification, the second one is Powell's classification, and the third one is your Gardner's classification, right? So these are the classifications. Coming to the anatomical classification, this is the anatomical classification, where based upon the anatomy you divide. So I have told you this is the fracture neck of the femur, right? So when it is just below the head, this is called subcapital. Capital matlab head, subcapital, so below the head, so subcapital. Then you say basal means just below the baseline of the fracture neck, just below the baseline of the neck of the femur. So this is basal. In between the neck is transcervical. Cervical is nothing but neck, right? Trans means in between. So this is your anatomical classification. We'll draw this diagram, put three lines, right? So subcapital, transcervical, basal. So basicervical, that is called basal or basicervical, right? So this basicervical is actually intermediate between IC and IT. Okay, so that is the anatomical classification. Then you have this Powell's classification. What is Powell's classification? You draw a horizontal line like this, and now this fracture fragment, you draw a line through the fracture fragment and connect this to the horizontal line. So whenever you get an angle 30, 70, so as the angle increases, that means the shear forces also increases, means is unstable. So instability also increases. So this is a stable fracture. That means the shear forces are less, and this is an unstable fracture. That means shear forces are more. Understood? So as the angle increases, the shear forces increases, the instability or the fracture becomes more unstable. So that is your Powell's classification. So anatomical, Powell's, And then comes the final one, that is the Gardner's class. So what is Gardner's classification? This is based upon the trabeculae. So if you see, there are certain trabeculae, so certain lines which you see on the X-ray. If you take a good X-ray, you can see certain lines. So these lines will be like this. So next time when you see a hip X-ray, try to appreciate these lines. Okay, you can see on the X-ray these lines. These are called trabeculae, and based upon that, the Gardner has formulated. So the first one here, what he has told is about the impacted fracture. That means here, first fracture, there is no displacement. So this is an incomplete fracture. Incomplete fracture, right? Second one is a complete fracture with no displacement, right? And the third one is a complete fracture with displacement, right? And fourth one is, so here it is partially displaced, here it is completely displaced. Understood? So that is the difference. So here, first one is an incomplete fracture. So this is the incomplete fracture. So how will you identify it's an incomplete fracture? This is usually not appreciated on the X-rays. Only you can see is, as I've told you, the trabecular bending, right? And the second one is the complete fracture. Because the fracture is not complete here, the patient can still come walking to the OP. Here the fracture is complete, but it is undisplaced. So the fragments are still aligned. So it is undisplaced, right? And the third one, if you see, it is partially displaced. The fracture is complete and there is displacement which is only partially. So fourth one is completely displaced, right? Having understood so much, you will not use any of this in your clinical practice. This is just a theoretical knowledge you have to. Okay, so this is anatomical, vowels and Gardner's. This is the classification. So what is important is clinical features. So once you come to the casualty, what is important is clinical features. So first, pain in the hip joint, history of trivial fall, right? And then non-weight bearing. Patient is unable to weight bear. So these are the complaints she will tell. And how do we examine? Will ask for active SLRT. We'll check for rotations, painful, and you go for an X-ray. And one more important thing is external rotated limb. The limb will be externally rotated, right? And in case of IC, because the capsule is holding it, it is not so much into external rotation, but in case of IT, it is completely touching the couch. Here, the externally rotated limb is there. And then you go for X-ray, we'll see for medial discontinuity, or sometimes the Shenton's line is broke, right? Fracture, if it is complete and displaced, you can appreciate on the X-ray, right? So this is the clinical features which you have to appreciate on the X-ray, right? So sometimes I forgot about the tenderness, right? Tenderness be groin or tenderness. So that are the clinical signs and symptoms. So this is the X-ray what I have bought for you. So if you see, this is an X-ray, right? So here you can see that the fracture here, this is the fracture. So this is the fracture neck of the fracture neck of the femur. So this is an IC fracture. And now what is this? An IT fracture. Okay. Now Main problem comes with the treatment of the one more thing I forgot is I have to tell you how this is externally rotated on the X-ray. So here if you see the lesser trochanter, is more prominent on the X-ray, right? And there will be proximal migration. So here what is more important is the proximal migration you can see, and then there will be lesser trochanter which is very very prominent. So usually the lesser trochanter, if you see, it is placed on posterior and the medial aspect of the femur shaft, right? So this is posterior and medial aspect. Posterior medially, that means, so whenever it is externally rotated, I mean if you turn your limb like this, now this lesser trochanter becomes very very prominent. So that is also an indication of an externally rotated limb on the X-ray, right? For any year the anatomy teacher is the same. Even if you're fourth year also, the anatomy teacher is Pradeep Pawar sir only. Welcome to the channel, Mika Tiwari. So that is it. So we have done with the clinical features and then we have done with the X-ray. So now the treatment. So this is very, very important, guys. The treatment is very, very important in case of IC fracture. And what you have to remember is in case of IC fracture, the treatment depends upon the age. So now you are having a IC fracture, right? And now the age is less than 60 years and more than 60, right? And if the age is less than 60 years, if the fracture undisplaced, can go for fix it. If the fracture displaced, reduce it, go for to fixation. Only if you achieve proper reduction, right? If the age is more than 60 years, if only head is involved, then we go for hemi orthoplasty. And if there is an involvement of acetabulum or any signs of arthritis, so directly you can go for the total hip replacement. So these are the options what we have. We have CC screw fixations, we have semi-orthoplasty, and we have THR. So when you go for CC screw fixation, it is called as osteosynthesis. That means osteosynthesis is bone formation. So we are encouraging the bone to form. So that is osteosynthesis. And for hemiarthroplasty and THR, this is called as replacement. So this is hemi means half, total means full. So when two articulating surfaces are replaced, that is acetabulum and hip are replaced, it is called as total. Only head is replaced, this is called as hemiarthroplasty. Orthoplasty is nothing but replacement. Understood? So that is about the IC fracture. So now these are the uh, three important treatments, right? So first is the CC screw fixation. So we use three CC screws and we go for an inverted triangular fashion, that you have to remember. And this is hemiarthroplasty. What is hemiarthroplasty? So where you replace the head. So here what we use is bipolar. So this is the prosthesis which we use. The prosthesis is bipolar prosthesis. Now, presently, in past they were using Moore's prosthesis and Thompson's prosthesis, right? Moore's and Thompson's have been used, but now it is the bipolar prosthesis which we are using. And finally, if you are having arthritis, if the patient is having arthritis, then we go for total hip replacement, where you replace the head and also the acetabulum. So this is the acetabulum we have replaced. This is the head. So now these are the screws into the acetabulum, right? So this is the total hip replacement. So these are the treatments for your IC fracture. And now, what are the complications of IC fracture? This is very, very important. What are the complications of IC fracture? So first and foremost, it is non-union. As I have told you, it is non. Then second, it is avascular necrosis. And third, it is osteoarthritis. So how do you identify the non-union? Because on the X-ray it is difficult, so we usually go for CT scan like this. This is the non-union. So you can still appreciate that the fracture has not healed in spite of implant which is placed. So this is because of the implant failure. As I have told you, like the surgeon, if does not reduce properly, so this has become because maybe because of the reduction or because implant is not, you know, adequate for that particular, or the patient immobilization protocol if has put weight at early stages, then it will result in non-union. So these are the various these are the three important complications of IC fracture, that is non-union, avascular necrosis and osteoarthritis, right? Then small things about IT fracture. So we all know intratrochanteric fracture, that is an extracapsular fracture. It will result in malunion. The treatment here, it is usually the dynamic hip screw or the proximal femoral nailing. Okay, dynamic hip screw or the PFN or proximal nailing, and the complication could be malunion. What is Volkmann's contracture? Yeah, investigation of choice is MRI. Very good. For avian, you have to go for MRI. And usually all the three we usually treat with THR only. But still you can try the non-union. You can try with certain osteotomy also. And of the complication. You can try with osteotomy and avian and osteoarthritis. You for THR. The treatment would be THR. Okay, and IT fracture, if they ask you about IT fracture, everything similar to the IC, but what you have to remember is it is exaggerated. Exaggerated, that is the malunion is the complication of the IC fracture. Again, it can also result in osteoarthritis also. IT also can result in osteoarthritis. Which fracture complication is Volkmann's fracture? Okay, so that is about your IC fracture and IT fracture. Okay, is this clear? Okay, now the last question. Get up for the last one. Yakini. Salam. Walaikum assalam. Mumin. Okay, so that is the posterior dislocation of the hip. The final question is posterior dislocation of the hip. Discuss the causes, the clinical features, complications, and the management. So the final question, but very, very important question. So dislocation of the hip is an important question where it will result in certain problems again. So whenever there is dislocation of the hip, you have to start with three. So the dislocation can be anterior, posterior, and central. And what we are interested here is posterior, because the most common type is posterior, right? The most common dislocation of hip is posterior, whereas the most common complication of the shoulder is, yes, Kalai and Jitu, which is the most common type of shoulder dislocation? So this is the articulating surfaces are displaced. So what is the definition of A? Most common type of dislocation in shoulder is inferior, Jitendra. It is anterior, right? In shoulder, it is anterior dislocation. No, no. Yeah, anterior dislocation, shoulder. In hip, it is posterior dislocation, right? Okay. What is the definition of hip dislocation? You see the articulating surfaces such as what are the two articulating surfaces here? One is the acetabulum cup and uh, the head of the femur, right? The socket, right? So this is the cup, I mean this is the ball and this is the socket, right? So the acetabular cup is the articulating surface of the head of the femur. Now when this gets displaced, that is called dislocation, and this dislocation commonly occurs posteriorly, and hence it is most common type. And then what you have to remember is what are the causes of it. So usually the causes is of high velocity force, and for posterior dislocation, what you have to remember is there is one thing which is called as the dashboard injury. The dashboard injury is a complex. Dashboard injury is a complex where you see certain things. So first one is the posterior dislocation of the hip is very commonly seen in dashboard because of the posture where we sit flexed knee, and whenever there is a hit, so this will hit directly onto the knee, right? So here hitting of the knee will result in patella fracture, which is a direct contact, and indirectly it will push the hip posteriorly, which will result in posterior dislocation. And third one what we see is PL injury. PL injury, that is posterior ligament injury. So this is called as the dashboard injury complex. So whenever a patient tells you the mechanism of injury as high velocity forces dashboard, to suspect for patella fracture, you have to suspect for PCL injury and look for posterior hip dislocation, right? Posterior hip dislocation. Is that clear? So that is about the dashboard injury, right? And now whenever there is dislocation, it is very painful, and you can't examine the patient. It is such painful, they will not allow you to touch. So here what helps us is the attitude of the limb. So what is the attitude of the limb in posterior dislocation? Quick. Attitude of limb in posterior dislocation of hip. So attitude of the limb here is it goes into flexion, adduction, and internal rotation. So you have to remember that this is also an emergency case of orthopedics. So whenever you see any dislocation, they are supposed to be an emergencies. So here you have to remember that there is an attitude of the limb. So this attitude of the limb in posterior is far their flexion, adduction, and internal rotation, whereas in anterior dislocation it is fiber, that is flexion, abduction, and external rotation. Very good. So this is the attitude you have to remember. So important is your posterior limb attitude. So posterior hip dislocation limb attitude, and then you can see that because of this attitude of the limb, right, and then you can suspect and send the patient for the x-ray. On the x-ray what you see is definitely there will be break in the Shenton's line, right? X-ray you see there will be a break in Shenton's line, that is for sure. And then you see there is a displacement of the femur. So there is a displacement of the head outside the acetabulum, posterior aspect. And here if you can see something which is interesting, I have told you externally rotated, yeah, limb shortening is also seen. So externally rotated, the lesser trochanteric becomes prominent. Now can you say what is the lesser trochanteric position? So you can identify lesser trochanter here. So I can appreciate there is flexion, and then there is adduction, then there is internal rotation, right? So on internal rotation, what happens to the external lesser trochanter on the X-ray? See, what did I told you about lesser trochanter? So lesser trochanter on external rotation becomes more prominent. That is for IC fractures we have learned, right? But internal rotation, whenever you go for internal rotation, the same lesser trochanter will be less prominent or not visible. So whenever you don't see the lesser trochanter, see, you can't appreciate lesser trochanter here, right? So that means the limb is internally rotated. Understood? Now go back to the IC fracture. What did I tell? In IC fracture, what did I tell you? This is the lesser trochanter. It has become more prominent. That means the limb here is externally rotated. So based upon this lesser trochanter, you can tell, yes, lesser trochanter is rotated to back. That is because of the internal rotation. Lesser trochanter here, it is externally rotated in IC fracture, and in case of your posterior dislocation of the hip, it goes completely back, so you can't see the lesser trochanter. That means you can tell that it is internally rotated. So that is the attitude of the limb, right? So lesser trochanter is absent, or you can't see, or it becomes less prominent. So that are the features of your X-ray, right? That are the features of the X-ray. And once you confirm the diagnosis, so it is an emergency. You have to immediately reduce. So this reduction is, first it is always closed reduction, right? Have to try closed reduction usually under anesthesia. So how you do this closed reduction? Have to take the help of your assistant. So patient will be supine on the floor. So usually under anesthesia. So first what you do is your assistant will stabilize the pelvis. So this is the reduction maneuver. The assistant will stabilize the pelvis. Then you flex the knee 90 degrees slowly. Give longitudinal traction. Give longitudinal traction, and with that you can hear a click sound, or then you do, okay, usually what we do is we do it on the floor, supine on the floor, because on the OT table again you have to put a stool and then you have to pull it up like that, no? So that is why we ask the patient to put the patient on the floor, and then we give longitudinal traction, right, with anesthesia. Once giving longitudinal traction, you can hear a click sound, that it gets reduced. It gets reduced. Okay, so that is how you reduce the uh, dislocation. So once you try for close reduction under anesthesia, and then if not reduced, or if it is associated with fracture, then you go for open reduction, right? So anyways, you try to reduce it. Once you reduced, you go for immobilization, or, right? So that is the protocol. So once you reduce it, even if you're unable to reduce, you go with open reduction. So once you have reduced it, you go for immobilization for 3 weeks, right? So on OT table is also fine, but usually for the convenience, we put the patient on the floor and we'll try to reduce it. So this is the maneuver for the reduction. And then what would be the complications of the non-union? So what you have to remember is the complications and dislocation, that is avascular necrosis, is very high. It is almost up to 40%, right? So usually you have to be very careful whenever there is a dislocation, because you have to immediately reduce, otherwise the chances will increase, the chances of AVN will get increased. So what is avascular necrosis? I've been talking about AVN, AVN, AVN. So AVN is nothing but loss of blood supply to the head, which will result in necrosis. So initial necrosis is not seen on the X-ray. So you have to go for MRI. But late, after like 3 months of certain necrosis, you can see on the X-ray. Right? So this is the avascular necrosis. So you can see the avascular necrosis of bilateral heads. So first complication is AVN. And the second complication is osteoarthritis. So this is also very, very important. The patient may land up with osteoarthritis if not treated well. Then you can see what is called as myositis ossification. It's also important. So again, what are the three things? So first is AVN. The second one is osteoarthritis. Third one is myositis ossification. Right? This is all you have to write for posterior dislocation. First, you start with the dislocation definition. Then you write the causes, the high velocity, the dashboard injuries. Then clinical features, mainly you put the attitude. Then X-ray, you write about the of lesser trochanter and disarticulation. Then after diagnosis with the X-ray, you immediately go for reduction. So reduction maneuver you can write as longitudinal traction with knee flexed up to 90 degrees. And then after that you go for immobilization for right. And what are the complication expected? The complication expected are avascular necrosis, osteoarthritis, and ossification. Fine. So this completes your posterior dislocation of the hip. Now, recently they have started with MCQs also in your theory, right? I have heard like certain universities have started, so I have brought up to certain MCQs also for you. So, will you answer the MCQs? So, I will do it quickly for you. So, last stage of fracture healing is remodeling, right? So remodeling is the last stage of fracture healing, right? And then commonest type of hip dislocation is, yeah, C, correct, Amir. What is the commonest type of hip dislocation? We have discussed it here also. What is the commonest type of hip dislocation? It is posterior, right? Very good. B. Yeah, then method of immobilization of fracture shaft femur. Method of immobilization of fracture shaft femur. Is it PTB cast, the Thomas splint, or derotation boot, or KT brace? Yes, the answer is B. It is the Thomas splint, right? So derotation boot is usually for IT fracture, right? And then the most preferred treatment for neck of femur fracture in a young adult. Yes, very good. Thomas splint is the right answer. What is the most preferred treatment for neck of femur fracture in a young adult? So neck of femur, young adult. So they have made it clear for you. It is never conservative. Young adult, you want to go for total hip replacement? So that is for Thomas splint you are typing. Okay. Yes, fixation with the C. The right answer. Fixation with the CC. Very good. Most common deformity following supracondylar fracture humerus. Valgus, varus, genuvarum, coxa valga. So what is the answer? Most common deformity following supracondylar fracture humerus. Is it valgus, varus, genuvarus or coxa valga? Yes, it is varus. Correct. So these are the MCQs which have been asked. So this completes our class. And homework is, you all know, you have to read the entire trauma. And these are certain important questions which we have covered, that is frequently asked repeated questions for examination. So hope you have made it useful. And see, this is how to enroll. So who are new to this, fresh to the channel, we are from the PW MedEd. We have an app, and you can go to the Farre series there, and you can explore what various other subjects as well. Okay, so thank you so much for your patient listening, guys. Hope I have not taken much of your time, guys. Thank you. See you all. Good night. And you can contact us anytime at PW MedEd. We are available on Insta, or you can DM me directly to Dr. Alekhya Ortho on Insta. Right? We are here to respond, and we are here to help you personally, professionally. Okay? So that's the end of the class. Thank you so much. Next, for a series, I'll come up with the infections and inflammatory disorders. Okay? Yeah, Kala, it has become little long, but useful, right? Thank you so much. This is my daughter Adya. She wants to say bye to you all. Bye.